And so I can just give this back?
Yeah, you're done. Somebody else is going to use
is not what's on course one, but.
I think it was matches, right?
No, my one is coursework.
Sorry?
My coursework one.
Yeah.
I think last time that they said, like they took cost however many.
Oh, did they on that one?
I'm so sorry.
Thank you.
Computers are such. Take as long as you need it. That's Oh no.
One question is round and then you get it.
Oh. What can you do?
Finish her up. You can step it up there.
I never returned it, so I'm just curious. I did just do last name.
Samson?
What made you think of that? Seeing them people
I just don't remember because no one.
I don't even know what that is.
You sure?
No. Yeah.
Yeah, of course. Yeah, T-E-A-K.
I have to get back on.
I will, yeah.
Last name? Oh, you did? Last name?
Hey, Patel.
Last name?
Fallon.
Margaret?
Sylvia Fallon.
Just kidding. Oh, here we go.
H-S-I-D-H.
Oh, wait.
Son S-O-N-G.
Sure.
Davies.
G-U?
do it. I didn't do it.
No.
Other five.
Okay. You might have your other one.
Okay.
Amy.
Thank you. Oh, really? Then I can totally live. Okay, but I'm gonna stay and just listen. I'm gonna get a snack.
Last name?
It's Ohan. O-H. Sorry.
Rachel?
Yeah.
My last name?
Diana. Thank you. First name Catherine. Okay.
Here you go.
Thank you.
Yeah, last name?
Smith.
Smith.
Oh, no. I'll just wait for him.
Barry? Okay, but Don Ring?
That's me.
Last name?
I just want to turn it on.
Jester, J-E-S-T-E-R.
Last
nice and crowded. At least I heard I heard it was warm the last time it was in here, so it's a little bit cooler. I'm sure it'll get warm in a couple hours. Okay, so today we're going to finish up by talking with respiratory pharmacology, we'll start with, and then endocrine pharmacology. Specifically with respiratory, we are going to focus on those drugs that are used for asthma and chronic obstructive pulmonary disease. There's a lot of overlap between the two, so you'll see that in the COPD section, there's not much drugs because a lot of them overlap with the drugs that you use for asthma. There's just some nuances that I'll point out in terms of which you would start first versus which maybe you wouldn't go to in a COPD patient. And we'll focus more on the smoking cessation because that's really what you need to do for patients who have COPD because there are no medications that will actually stop that process. So let's start off with a little bit of pathophysiology for asthma. If you take away anything from this slide, take away that first statement. It is a chronic inflammatory state. It is a chronic inflammatory state, and that's going to come back to us when we talk about the medications. So there's going to be medications that will treat the initial bronchospasm that's associated with asthma, and then there's going to be medications that treat the underlying condition, which is an inflammatory state, so we're going to look at those anti-inflammatories. With asthma, patients will present with recurrent episodic bouts of coughing, wheezing, shortness of breath. Is this too loud? No, I feel like I'm hurting my own ears. Okay. You do get narrowing of the trachea and bronchi, and you have contraction of smooth muscles and so forth. The thing with asthma, though, is this is reversible. Okay? If you do not treat the patient, it becomes irreversible. However, we have medications that can treat the underlying inflammatory process that occurs with asthma, and so all of this can be reversible, and people will not have long-term sequelae with breathing problems when they have asthma. Still staying on pathophysiology, you essentially have different types of allergens or something that attacks your mast cells. And within your mast cells, you have inflammatory cells and mediators. You do not need to memorize which of these are cells and which are mediators. So I will never ask you a question of is histamine an inflammatory mediator or an inflammatory cell. But it's important to know that there's two that come out of the mast cells because you see these two characteristic signs with asthma. Is you have that bronchoconstriction, which makes that patient not be able to breathe, and then you have that chronic inflammation from the inflammatory cells. Still staying on pathophysiology for a little bit, you have the acute phase of asthma. And this is where the allergens will provoke IgE production. So it's going to hit the mast cells. Those mast cells are going to explode. You're going to get the first wave of bronchoconstriction associated with asthma. Then the patients might get better, and then they may go into a second phase, or what we call the late phase. And that typically occurs about 3 to 6 hours after that initial phase. This is a more sustained phase of bronchoconstriction. This tends to last sometimes days to weeks for patients, and this can be quite difficult to treat. So when you're treating patients that come in with an asthma exacerbation, it's important to hit them hard in that early portion and prevent them from going into that late phase, because this is where patients then will have that prolonged bronchoconstriction, a prolonged recovery time. And then, as mentioned before, there are chronic effects. So you can have airway remodeling. Okay, this is an inflammatory process. So when something stays inflamed over a long period of time, you're going to see changes over time. Same thing happens with the heart muscle when you have heart failure. You hypertrophy the heart, and it doesn't work the same way. The same things are going to happen with your lungs. So over time, with continued inflammation, you're going to see chronic changes, and they're not going to be reversible. But again, because we have medications that are anti-inflammatory medications, you will reverse that process that's associated with asthma. So pictures, always like pictures. So this is what a normal airway would look like. So you can see a very nice bronchus here, which is nice and open. And as you see more inflammation, it becomes more thickened and harder to breathe. Shoot. Okay, there we go. Goals of asthma. We want to prevent that pathologic triad, which is bronchospasm, those retained secretions, and mucosal edema. So all of our medications are going to target at limiting those, the triad. We want patients to have minimal or no chronic symptoms or exacerbations. Patients will oftentimes use a lot of medications, and we want to minimize the use of the rescue medications for these patients and maintain normal activity levels while doing so. And as always, we want to minimize the adverse effects. And you'll see that with some of the asthma medications, we have different routes for a lot of these medications, and everything is really going to be minimized when you can give it via the inhalation route, because you're getting to the site of action where you need, as opposed to giving something systemic, which is going to have much more side effect profile. All right, so we're going to take all the medications for asthma, we're going to group them into 3 groups. We're going to have the bronchodilators, the anti-inflammatories, and we have one immune globulin antagonist. So we'll start with our bronchodilators. The first group are our beta-adrenergic receptor agonists. So this is in words the mechanism, which again, for testing purposes, I would strongly recommend that you know mechanisms of action. I'm going to jump to my poor picture of a lung. But if you will, what happens is your lung has beta receptors. Well, I'm going to take one step back here. What normally happens in your lung is you generate ATP, which makes cyclic AMP and causes relaxation. So that's how what's normally happening in your lungs when you're sitting here resting, you have this bronchodilation. Of course, in any state of like a fight or flight, when you have more epinephrine, of course you're going to get more bronchodilation. But in a normal state, this is happening. So your beta agonists are just going to simply work on that beta receptor, and it's just going to intensify this process. It's going to take more ATP, make more cyclic AMP, and cause more relaxation, or another word to say it is bronchodilation. So all you're doing with your beta-adrenergic agonist is you're augmenting what already normally happens in the lung. Now, before we talk about mechanisms and side effects, yeah? I don't know that I can turn the volume down, but I can maybe. It's like one, it's on or off. Sorry. Is anybody else having a problem with the sound? Okay. I guess we're the only two with sensitive ears. Okay, so it's important to know that there are different beta receptors in different parts of your body. So in the lungs, you have your beta-2 receptors. That predominates in the lungs. And when you activate those receptors, you're going to see relaxation of smooth muscle, and that's going to lead to the bronchodilation. In your heart, you have beta-1s, which predominate, and you have beta-2s. So with that, when you activate those receptors, you're going to see an increase in heart rate. You might see increase in contraction. Now, it depends on what you're trying to treat. When you're treating an asthmatic, you want to target those receptors in the lungs, because that's where the problem is. If you're treating somebody with heart failure, you're going to target those beta receptors in the heart. So you can see that there's drugs, though, where we'll talk in a little bit about selectivity, though. There are some drugs that are not going to be selective. So in the case of asthma, we're going to hit those beta-2s in the lungs, but perhaps we'll cause some side effects where we'll see increased heart rate, and not necessarily a side effect of contractility, but mostly the heart rate is going to be problematic with these agents. So ultimately, what we're looking for with these agents is a therapeutic effect of bronchodilation. Additionally, these agents will also inhibit the release of those bronchoconstricting mediators, and it will allow for increased mucus clearance, which can be very helpful in patients with asthma. Again, they have that buildup of mucus, kind of opens things up, and then they can cough it out. Okay? So important to understand the 3 things that you're accomplishing with your beta-adrenergic agonists. Now, I did touch on this 2 seconds ago, where you have selective agents and you have non-selective. So you need to kind of refresh your brain because we talked about this in the cardiovascular section. But now when we talk about selective and non-selective, it's the opposite in terms of the receptors that we want to hit. So those agents that are non-selective are going to work on both the beta-2s and the beta-1s. And so you have some examples, and for those of you who remember my style, when things are in yellow, that's a suggestion that you should know these drugs for the exam. Okay, so something like epinephrine is a non-selective beta-adrenergic agonist. So it's going to work on beta-1s and beta-2s. So it's going to hit those receptors in the lungs and in the heart. Now, in direct opposition to that, you have selective agents. An example would be something like albuterol, which I'm sure many of you in this room are familiar with. That is going to act more selectively on the beta-2 receptors. So we're going to target those beta-2s generally in the lungs. Now, there are some beta-2s on the heart, but because we're not really getting those beta-1s, these are going to, in general, have less side effects than our non-selective agents. Okay? So if I was talking in the sense of asthma, and I said a drug was non-selective, I'm hitting what receptors? Beta and 2. If I said it's selective, I'm hitting beta 2. Good. Okay, we kind of already touched on this. So the key advantage of using those selective receptors is that you're targeting the receptors in the lungs, those beta-2s, and minimizing the side effects, which would be particularly cardiac. However, just like I talked to you guys in the cardiovascular lecture, nothing is ever absolute. So if I sat here, so let's take, for example, albuterol. It's a selective agent targeting beta-2 receptors. And I'm going to use it via inhalation. So I'm going to have minimal systemic absorption. We'll go through this in slides. I'm just trying to put this in context now, so you don't have to feverishly write this down. So I'm going to inhale it. I'm going to be selective to the lungs. I'm going to have minimal systemic effects because it's in the lungs where I want it to work. But if I sat here and I puffed on that albuterol every second, I'm going to lose that selectivity because I'm going to saturate my lung receptors. I'm going to have some systemic absorption, and the more I use it, the more absorption I'm going to get. I'm going to spill over and hit those beta-2 receptors on my heart. Okay? So when you say something is selective, it is selective, but of course in extreme circumstances it may not be. And there may be some, I'll tell you, the first time I used an albuterol inhaler, I was shocked. I mean, I had tremors, my heart was going to jump out of its chest. So everybody's going to be different. Everybody's going to have a different response. But in the sense of selectivity, you shouldn't see those systemic side effects, but everything can spill over and everybody's a little bit different. Just like we talked with the beta blockers. Do you remember we said some were selective, but when you get to the really high doses, they become non-selective. Okay, then we break it down even more. And now we take our agents and we call them either short-acting agents or long-acting agents. So they're, in the literature, you'll see this termed as SABA and LABA. Our short-acting agents really should only be used for an acute situation. So for patients who are having an exacerbation and they need quick relief. Okay, so short-acting means it's going to be quick in onset and it's going to be quick in offset. And I'll give you some examples in a second. Long-acting agents always universally should be used for maintenance therapy. A patient having an acute exacerbation should never reach for a long-acting agent. These agents don't work as fast, and in somebody having an acute exacerbation, they need something that works fast. So LABAs are only for maintenance, and SABAs should only be used really for quick relief. So here's some examples of what this would look like. So if we took something like epinephrine or albuterol, these are considered short-acting agents. Remember, epinephrine's non-selective, but albuterol is selective. So each agent has a selectivity, and then it's classified as SABA or LABA. Your short-acting agents will work in less than 5 minutes, and they have a short duration of action. So they need to be continuously administered in order to see sustained effects. Now, when you talk about your long-acting agents, their onset of action is going to be about 30 minutes. So again, you would never, somebody having an exacerbation, you would never want to reach for a LABA because it's going to take 30 minutes to work. However, the duration is going to be closer to 12 hours, so half a day. So you don't need to administer these drugs as frequently. And some examples would be salmeterol or formoterol. Okay? So that's why, again, every agent, so when studying for this exam, you should be able to take those agents in yellow and say, is it short or long acting? Is it selective, non-selective? Now, routes of administration. Always the preferred route for somebody with asthma in a beta agonist is going to be inhalation. That's what you're targeting. You're targeting the lungs. You have about 10% of inhalation drugs that will get absorbed systemically. So you will get about 10% of the drug that you inhale, you will get some systemic absorption. But imagine I took something as an oral tablet. I'm getting 100% systemic absorption, okay, depending on the bioavailability. When we talk about administration by the inhalation route, we can even break that down a little bit further. We can have a metered dose inhaler, or we can have dry powder, or nebulization. And which we're going to choose is really going to be dependent on the patient that's presenting to us and other comorbidities or ambidexterity or whatever the case may be. How many, just a show of hands in the class, how many have seen or used a metered dose inhaler? Okay. So in brief, the cartridge or the delivery device is separate from the drug, and the drug comes in a canister. And the drug has the canister has a propellant in it. And the propellant goes, when the canister is resting, the propellant comes to the bottom and the drug goes to the top. So it's so important that patients understand that they do have to shake the canister very well before administration. If they don't, all they're going to get is propellant. Okay, that's one problem with the metered dose inhaler. So imagine kids. Kids may or may not remember to shake it. Now, with the metered dose inhaler, you have a breathing technique that needs to be done in order to get appropriate deposition of the drug into the lungs and not just have it sit in the back of the mouth. So you have to breathe out slowly, and then while you're breathing in slowly, you have to actuate that metered dose inhaler. Okay, so it's not a kind of thing that happens, okay? So imagine your elderly patients or patients with Parkinson's disease or Alzheimer's disease, patients who don't have that ambidexterity, they're not going to get the drug into their lungs. And really, for a very long time, that's the only way we had to deliver these medications. We're using the metered dose inhalers. So then they came out with dry powder inhalers, which were a little bit better. You still had to have the same kind of breathing technique where you breathe nice out and you breathe slowly in, but you don't have to, you can click your medication in the cartridge separately. You could wait a while if you wanted to. And then you just simply put the device to your mouth, and when you're ready to breathe, the drug will be delivered. So you didn't have to worry about pushing down and breathing at the same time. And of course, nebulization. You throw a mask on somebody, and the drug is nebulized through the mask, and really all the patient has to do is breathe. So you can imagine that somebody in extremis coming in with an asthma exacerbation, they're certainly not going to want to be pumping and puffing at the same time. They're also not going to be clicking and taking in the dry powder, and so nebulization is probably the key to go with somebody with acute exacerbation. Okay, and you don't need to memorize which drug comes as which form. That was just to give you some examples that some medications are available in multiple different dosage forms and some are available only as one. And then here just it recaps what we already kind of talked about, some of the advantages and disadvantages of the metered dose inhaler versus the dry powder inhaler. So everything that we've kind of covered. Now, again, our kind of always the route we think about with these meds is inhalation, but there are other dosage forms that these drugs come as. So we have oral dosage forms. Again, when you're taking something oral, you're increasing your risk for side effects, specifically cardiac. And albuterol still comes as a capsule. There are some real severe asthmatic patients where this is the medication that they need to use, so it is still out on the market. But that's pretty much the only drug that comes as a capsule. And then, of course, you can also give a number of the beta agonists as subcutaneous administration. The more typical drug that's given is terbutaline. That's generally seen in the pediatric patient population. Every once in a while, you'll see it administered in the emergency department. But again, I think you have to be very cautious when you give a beta adrenergic agent to, let's say, a 70-year-old woman who comes into the ED, because what's the first thing that's going to happen? You gave her a little heart attack. Yeah, so usually a non-STEMI, but she leaked out some cardiac enzymes because, remember, when you give something parenteral, you're going to increase your risk for that side effect, and her heart rate probably shot up to 160, 150s. Make sense? Okay, so adverse effects, I would definitely know these. These are important. We've talked about a number of them. So tachycardia, again, that's going to be minimized by using the inhalation route. But this is because you have that direct stimulation on the beta-1 and beta-2 receptors of the heart. Additionally, some other side effects you can see are some electrolyte derangements, which really is only potassium. So albuterol will push potassium intracellularly. Is this a problem that somebody who's on maintenance medications of asthma? No. Does this become a problem with somebody who is on nebulization every 30 minutes? It could be. In fact, nebulized albuterol is in the algorithm to treat hyperkalemia when you can't use some of the other medications. So you do have to think about this, again, in patients who come in with severe asthma and they're taking a lot of albuterol, or they did at home and they're presenting, you do need to think about potassium. Now remember, it's not their total body potassium that's down. You've pushed it all intracellularly. So it may lead to cardiac arrhythmias, but as soon as that albuterol wears off, that potassium will come back out extracellularly. Tremor is also a problem, so you stimulate your beta-2 receptors in your skeletal muscle. Sometimes that's the endpoint that we look for in patients. So if somebody comes in with a severe asthmatic attack, we'll look for those endpoints of tremor and tachycardia because we know then we've saturated all the lung beta-2 receptors and we're now spilling over into the heart. And then tolerance becomes a problem because over time, as your body continues to see beta-2 agonism, you're going to downregulate those beta-2 receptors. And so if I used continuous use of a beta-2 agonist for a month, 2 months, I'm not going to see the same effect 3 and 4 months out. I'm going to have to use more of the drug in order to see the same effect. So you downregulate those beta-2 receptors. If you take away the drug, you will upregulate your receptors. So then if you go back to the drug, you'll see a nice effect to a low dose. Okay? Significant drug interactions, anything that's going to work additionally on the adrenergic system. So anything like caffeine to stimulant, Sudafed, anything that's going to cause that cardiac stimulation is just going to be additive. So you're going to see increase in heart rate and other cardiac effects. And then beta blockers, patients who your therapeutic effects of beta-2 agonists may be, is that right? Oh, yeah, because you're blocking the beta receptor. So if patients on beta blockers, you're blocking perhaps some of your beta-2 receptors on your heart because we have non-specific beta-2 receptors. And so if then you go to give a beta adrenergic agent, you may not see the same therapeutic effects. So I oftentimes get the question of, are beta blockers contraindicated in patients with asthma? And the answer, it's a little bit of more of a gray zone than when you talk about COPD. But with asthma, kind of the going party line is how severe is their asthma. So in somebody who has intermittent asthma or persistent mild or even persistent moderate, so they're not on a large dose of maintenance medications, beta blockers are not contraindicated. But if you have somebody with persistent severe asthma, so they're on very high doses of maintenance medications, then you will probably refrain from beta blockers. Okay. Some patients with even mild cases of asthma, you'll give them a beta blocker, even a selective beta blocker, and you'll trigger an asthma attack in those patients. So it's not 100% contraindicated. Clinical uses, so we'll use our beta-adrenergic agents in acute episodes of asthma. So these are patients coming in with extremis. In this case, you're going to want to use short-acting agents, and you're going to want to use inhalation as the route, or you could use parenteral. Okay? Inhalation, what preferred inhalation route would you use for these patients? Nebulizer, right. You're going to stay away from the meter dose inhalers or the dry powder. You can use, and are you going to, sure, I already said short acting. For maintenance therapy, this is your LAVA, so you're going to use your long acting agents. You could use inhalation, and that would be the preferred. You could also use oral, but remember with oral, you're increasing your risk for systemic side effects. And then finally, you can also use these agents for prophylaxis prior to exercise or known allergen exposure. And in this case, you can use either short or long-acting agents, and you'll generally just use the inhalation route. So this is somebody you're going to have to, whether you use a short or long-acting agent, this is going to be really patient-specific. So let's say somebody plays a sport. Let's say they play basketball. And they never really know when they're going to play basketball, but that's what this exercise induces their asthma. So they carry around, are they going to carry around a short or a long-acting agent with them? Short-acting. They don't know when they play. It's not routine, so they can't time it. If I said I could only give them a long-acting agent, how long in advance would they have to use the medication before playing basketball? Good. So you guys are ready. 30 minutes before the exam. Right. We'd have to give enough time for that long-acting agent in order to work, in order to effectively hit those beta receptors to then prevent, when that person was playing basketball, that allergy. Same thing with allergen exposure. You know you're going into, or you're going to clean your house and there's lots of dust, you would probably carry around a short-acting agent with you. Now there are some black box warnings that are very important with the beta-adrenergic agonist. Essentially, and this will make a little bit more sense once we talk about the other groups of medications, but let's go back to what I initially said at the beginning of the class. What is the underlying problem with patients with asthma? Inflammation. Are these agents that we're talking about, these beta-adrenergic agonists, are they anti-inflammatories? No, they're just bronchodilators. So when you're using a bronchodilator in a patient for long-term maintenance, are you correcting the underlying problem of the disease? Would you see remodeling? Yes. Right. So what happened is back in the 90s, we didn't understand this concept, and so we treated patients with long-acting beta-adrenergic agonists as their primary maintenance therapy, and they didn't do well, and there was an increased mortality. Once we introduced anti-inflammatory agents for maintenance therapy for asthma, we have much better outcomes today. We have less pediatric and adult patients coming in with asthma exacerbations because we're treating the underlying cause. So there is a black box warning saying that you may not use a long-acting or even a short-acting agent, for that matter, as maintenance therapy with somebody with asthma. They must be on an anti-inflammatory because you need to treat the underlying problem. Now we're still in the family of bronchodilators, and this is the next class. These are the methylxanthines. Now this is in words, and we go back to my awesome long hair. So what normally happens is we have ATP, which makes cyclic AMP, which causes relaxation. We talked about that already. But cyclic AMP doesn't hang around for a lifetime, and remember, for everything that happens in our body, we have an equal and opposite reaction. So we'll break down cyclic AMP by an enzyme called phosphodiesterase. Okay, so that enzyme is phosphodiesterase. It's on the slide previous. And it breaks it down to 5' AMP, which really does nothing. But you're breaking down cyclic AMP. So with the drug, you're going to inhibit that enzyme. These are your methylxanthines. You'll increase concentrations of cyclic AMP, which leads to relaxation. So you're taking what normally happens in the body, which is this process of breaking down cyclic AMP, which then you'll get less relaxation. You're inhibiting that enzyme, causing increases in cyclic AMP and allowing for increased bronchodilation. Okay, so we've talked about two different mechanisms now with two different drugs that are bronchodilators. Now there are two drugs in this class. Theophylline is only available as an oral agent, and aminophylline is only available as an intravenous agent. There are a lot of theophylline. There are not many patients in this world that are maintained on theophylline, and we'll talk in a few minutes why. This is really considered a last-line agent for patients who are managed with asthma, and even for COPD for that matter. But when patients come in, just like we talked about with digoxin in the cardiovascular lecture, remember I said that there's multiple different agents out there? Well, the same thing is with theophylline. A lot of generic manufacturers of theophylline, and they each have a little bit different bioavailability. And so when you switch from one agent to the next agent, you can shift their body concentrations. And what do we call those drugs where when you shift them a little too much, you get no effects, and you shift a little too much and you get too much side effects? Narrow therapeutic index drugs. So that's what theophylline is. It has a very small window of therapeutic range of which a little bit below, it really doesn't have effects. A little bit above, you get too many side effects. So again, a concept here, don't memorize the different agents, but the concept is you really cannot switch these agents on a milligram to milligram basis. If you are switching the agents, you need to open up a textbook, look at the different salts that they have, and then there's conversions between one drug and the next. Again, clinical use is limited because it is a narrow therapeutic index drug, and you do have to monitor serum concentrations. You don't have to memorize the 5 to 15, but again, it is very narrow. Again, a little bit below, it's not effective, a little bit above, and it's too effective. The other thing with theophylline is the majority of the drug, about 90%, is metabolized by the liver, and it is metabolized through a number of cytochrome P450 isoenzymes. You do not need to memorize them, but it lends itself very nicely to drug-drug interactions. And that's with inducers or inhibitors. So very important when these patients are started on any inducer or inhibitor that they're having their drug concentrations monitored. Now, the adverse effects of theophylline. Now, we said mostly for narrow therapeutic index drugs, when you go up a little too much, that's when you see side effects. With theophylline, you can see any of these side effects at any concentration. They're magnified as your concentration goes up. You're going to see probably more magnified adverse effects. They're going to be a bit more severe. But the side effects that theophylline has are not to be glossed over. You can have significant CNS effects. Patients can present with seizures and end up in a coma. You have a tachycardia, some GI effects, and of course you still have that skeletal muscle tremor that you can see. But really it's those CNS effects, the drug interactions, that have really limited the use of this drug clinically. But where is it used? It can be used for chronic maintenance therapy in patients who have severe asthma. It's going to be one of those add-on medications. So you've maxed out on everything else, and you're just going to try theophylline to control this patient's asthma. It may reduce symptoms, and it may also increase the sensitivity of the beta agonist to those beta-2 receptors. It is less effective as add-on therapy than long-acting inhaled beta-2 agonists. And again, when we get to that, the step approach, this will make a little bit more sense. Because again, theophylline falls later in the algorithm, not in the beginning of the algorithm of treating asthma. So we're still in bronchodilators. Our last group are the anticholinergics. So we'll, once again, this is that last picture of the awesome lung that you see here. So what also happens in the lung is You will get vagus nerve stimulation, which leads to the production of acetylcholine, working on your muscarinic receptors on your lung, leading to an influx of calcium, which causes contraction of the lung. Okay, this is what normally happens. So what we'll do with our anticholinergics is we will simply block the muscarinic receptor. So we will not allow acetylcholine to bind to the muscarinic receptor. You won't have the influx of calcium, and you won't have that contraction. So you can see with these 3 sets of drugs that we have for bronchodilators, they're really working on 3 different mechanisms. One is a direct beta stimulant, one inhibits the breakdown of cyclic AMP, and the other one is a muscarinic receptor antagonist or anticholinergic. Okay, so we can hit people with 3 different mechanisms. To date, anticholinergics are really only available for inhalation. There are other anticholinergics that are available for parenteral administration, but not for asthma. Okay, so if you're treating in asthmatic patients with an anticholinergic, you would be only giving something by the inhalation route. There are 2 drugs, ipratropium. This would be considered, if you will, kind of your shorter acting agent because it needs to be dosed very frequently. It does work very fast in about 5 minutes, but it only has a duration that's about 6 to 8 hours. So it needs to be dosed multiple times throughout the day. And this does, and again, you don't need to memorize how it comes in, but it comes as a meter dose and also comes as a solution. So you can give these drugs via nebulization in somebody who has extremis. And then we have tiotropium, which works in about 5 minutes, but has a much longer duration of action for over about 24 hours. And this only comes as a dry powder inhaler. Now, has anybody used tiotropium? It actually has, the manufacturers are trying to get more creative with their delivery devices. So we started off with the meter dose inhaler, then we went to the dry powder inhalers. And I'm not exactly sure what the device is called for tiotropium. It's slipping my mind now. But at any rate, there's a lot of problems with this drug. The device is good, and it helps with compliance because how the patients prepare everything is the drugs come in a capsule. The capsule goes into the device. You click the device, and it punctures a hole through the capsule. And then you put the drug to your mouth, and when you're ready to inhale, you inhale slowly, and the drug is delivered. If you have properly delivered the drug to hopefully your lungs, not the back of your throat, it whistles, and it lets you know that the drug has left the device and has gone into your body, which is nice. But let's take the elderly patient that got the capsule, and they forgot they have to put it in the device, and so they just start popping their capsules. So they're not getting the effect. So nice manufacturing with the whistling of the device, but problematic for patients who have problems following instructions or maybe didn't understand the instructions or were never instructed. Because certainly it's a nice little capsule. It's very, that's what people do with capsules is they ingest them. So the patients who are on an anticholinergic for maintenance, they're going to see a decline because they're not actually getting the medication. The capsules won't dissolve in the stomach. You'll just, I don't know, for those of you who are wondering, it's not a true capsule. It won't degrade, and you'll just poop it on out. So no drug. Adverse effects with your anticholinergics, you'll see headaches, blurred vision, tachycardia, and urinary retention. So your patient who's puffing away on their Atrovent inhaler, they're coming in extremis. Oftentimes in the emergency rooms, you'll see big bladders. You stick a Foley and there it comes out because it's an anticholinergic, so you're retaining everything. Where are they used? Maintenance therapy for patients with asthma, but mostly your anticholinergics are used with your patients with COPD. For maintenance therapy, it's less likely to use with asthma, so this is going to be the mainstay when we get to the COPD section. This is pretty much the mainstay of therapy for bronchodilators. In asthma, it does have additive effects to your beta adrenergic agents, but only in combination. You would never have somebody coming in with an asthma attack and reach for an anticholinergic only. You would give them their beta agonist therapy, and you might add on an anticholinergic. They're synergistic when you use them together, but you would never use an anticholinergic alone. Okay, the next group of meds are anti-inflammatories, and as you remember, this is going to target the underlying problem of asthma. So we have our corticosteroids, and really they're anti-inflammatory. So you're going to see a reduction in your inflammatory or your airway inflammation. You're going to see decrease in that cellular congestion that you see with asthma. And steroids will also improve your beta-2 receptor sensitivity to your beta agonist. So it kind of has three things that it does. Hits those markers of inflammation, decreases congestion, and improves your sensitivity to your beta receptors. Corticosteroids can be administered by inhalation or parenteral. What would you prefer to give? Inhalation, right. You're targeting the lungs, less side effects. Goes with everything that we're talking about. The thing with steroids, though, is it's not immediate. So if you give a dose of parenteral steroids, you're not going to see the inflammation happen immediately. Why? Because you're preventing inflammation. Those inflammatory markers that are already released are causing inflammation, and it's going to take a while to bring those that have already been released down to normal levels. So you're going to see effects in about 1 to 2 hours. Now, if you're using inhalation corticosteroids, you'll see about 2 weeks that it takes to see improvement. So this is important. So if somebody comes in with an asthma exacerbation, think about what I told you earlier. They hit an early phase, and then they hit the late phase. So if somebody comes in, you want to hit them early on with bronchodilators because you want to treat their symptoms, but you also want to think about giving them some sort of anti-inflammatory. And you're generally, somebody in extremis, you're going to give parenteral drug to them. You're not going to treat maybe that initial phase if you catch these patients early on, but you're going to maybe prevent that second late phase from occurring because you're inhibiting that inflammatory reaction that occurs in that late phase. Okay. Question?
Would you ever give, so you're saying orally via inhalation, but would you ever give it by mouth as pills?
Yeah, I mean, you can give it orally. That's going to be somebody who is very severe asthmatic who has to take oral medications only for maintenance. You always want to give inhalation, and you'll see when I talk about the individual agents, there's escalations in doses. If they max out on those doses and still have problems, then you need to go to systemic.
Okay, and how long would that take?
So, I mean, in general, it's about, they have very good bioavailability, so if you gave somebody a pill, it would be about still 1 to 2 hours before you see effects. So here's the dose. I don't want you to memorize these doses at all. Those drugs that are in yellow, though, I would recommend that you know for testing purposes. What the concept of this slide is, as you can see, there's low dose, medium dose, and high dose. And what you can clearly see is that not every agent is the same. If you're prescribing somebody, and you'll see in the stepwise approach for treating asthma, you'll always start somebody with the lowest dose possible. So you'll open up a book, and you'll see where the low dose is, and you'll prescribe the low dose to the patient. If their asthma progresses and you need to step it up, you would go then to the medium dose or the high dose. But always trying to challenge the patient to get to the lowest dose possible. And you can see that these agents are generally not interchangeable in doses because they have very different dosing regimens. Another chart. Yeah?
Sorry, just to clarify, so you do want us to memorize the doses for those two that are highlighted?
No, I just want you to know those drugs, the drug names. If I asked you what is Pulmicort, you would know it's a steroid, right? Yep. A chart that, again, you don't have to memorize, but I would highly recommend that you understand the concepts on this chart and probably know the equivalent doses. No, you will not get the chart on the exam. But just very much similar to, like, do you guys remember, if you can dig back to your memories at the beginning of summer when we did the changes in the diuretics? This is something very similar. So when you talk about something's glucocorticoid component, you're talking about its anti-inflammatory component. So 20 milligrams of hydrocortisone is equivalent to 4 milligrams of methylpred or 5 of prednisone. So let's do a quick example. So patients taking prednisone 10 orally in the morning, what would be an equivalent dose of dexamethasone? Yes, you're right, whoever said it, but I was giving other people too. So if you just did simple math, you should get 1.5. Okay, with corticosteroids, what you want to try not to do is abruptly discontinue the corticosteroids. Now, some patients will suffer side effects. If they are side effects that can be tolerated, you want to slowly take the patients off of these medications. You also want to make sure and counsel them that they don't ever just stop these medications, because with abrupt withdrawal, that can elicit a very severe asthma attack. So if you can discontinue it over 1 to 2 weeks, but if it's a situation where the patient, it's the risks of stopping it are beneficial other than the benefits of keeping it on and not having a more severe reaction from discontinuing it, you need to discontinue it. I sounded like I just talked in circles. So taking the situation, if somebody can tolerate that side effect for weaning it off, you want to wean off steroids and never just discontinue it abruptly. Question? Okay. Adverse effects with inhalation, number one, hands down, are fungal infections in the mouth. So how do people get this? Well, your mouth is moist, it's dark, you're going to get steroid deposition in your throat, and guess what's going to grow? Nice white plaques, and you're going to get fungal infections on your tongue, underneath your tongue. So you need to make sure that when patients use their inhaled steroids, they rinse their mouth out very well after they use the steroid. Okay? Also, obviously, appropriate technique so that less gets in the throat and more gets in the lungs, but you always want to have them wash their mouth out very, very well to decrease their chances of oral fungal infections.
I thought you asked if they're supposed to swallow the water or spit it out.
I would just spit it out. Yeah. It's not going to harm you by swallowing it, but I would just spit it out. It's gross. Oh, no, I would just spit it out. Other effects, obviously, if you're taking systemic steroids, it can be very problematic, and there's a much more long laundry list of adverse effects. And I like to group them into those that are kind of more immediate versus those that are long-term. So immediate effects, you're obviously going to see changes in glucose and psychiatric disturbances. So patients can get quite wacky on high doses of steroids when taken systemically. Simply stopping them helps that. Long-term, you have to worry about osteoporosis and fractures, hypertension, thinning of the skin, not being able to fight off infections and have good wound healing. You get adrenal axis suppression, so your body can't mount the same type of response when it's under stress. Myopathies, immunosuppression, we already said, and then glaucoma. So lots of problems with taking parenteral steroids over a long period of time. So again, we may see patients with asthma exacerbations that need a short course of steroids, but then we always want to get them down to the lowest dose possible and inhalation as much as possible. Now, there recently, I would say about like 5 years ago, a black box warning came out on steroids. And steroids are essentially metabolized through the cytochrome P450 3A4 isoenzyme. And what was noted were patients who were on inhaled corticosteroids and then started on a potent 3A4 inhibitor, they ended up with Cushing's syndrome, and they had adrenal insufficiency. So essentially, they were on a dose of steroid, they were on an inhibitor, and so like the exposure to steroid exponentially went up in these patients. It was problematic with these patients. One thing to know, though, is the patients who they found this in, they were on very, very high doses of inhaled corticosteroids. So I'm not discounting this as a problem, but the majority of patients will be on mild to moderate doses of inhaled steroids. So it is problematic if somebody is on high dose or on oral systemic steroids. You do have to think about 3A4 inhibitors may increase that exposure to the steroids for that patient. Is it problematic with somebody who's taking it for a 10-day course or maybe even a 2-week course? Not so much. It's that patient that has to be maintained on those high doses or parenteral doses for prolonged periods of time in order to inhibit their exacerbations. So where do we use steroids? I already touched on this a little bit already. We use it in acute reactions. We give it up front. It's not going to work right away, but we're going to help prevent that late phase asthma that occurs. The first dose, probably going to give it intravenously. The patient's in extremis. They're not breathing well. They're not going to be able to swallow medications. So we can give it IV, and then we can follow up with a short course of oral therapy. They can also be used to prevent attacks. Remember, the underlying problem with asthma is inflammation, so we're going to use this as maintenance medication. Again, inhalation is always preferred over oral. And then the dosing should be based on the severity of the disease, which we talked about. You do not have to memorize this, but just like we talked about in the antihypertensive lecture, there's a lot of combination medications out there. So here's an example of some of the combination meds. But again, if you looked up what Advair is, and you saw that there's salmeterol and fluticasone, you should be able to say, I know what fluticasone is. It's a corticosteroid. And salmeterol is a long-acting beta agonist. So you know the components of the medications that are in a lot of these combination drugs. Okay, our next group of anti-inflammatory agents are the leukotriene modifiers. Now, what happens normally in the body is leukotrienes are formed from arachidonic acid. And essentially, leukotrienes are potent bronchial smooth muscle constrictors. So we normally have the production of leukotrienes. We normally get bronchoconstriction from these. But again, in somebody with asthma, they're going to have an overproduction of these leukotrienes. So there's a number of leukotriene subtypes. So LT is leukotriene, and then there's the subtype C4 and D4. And those are really your most potent leukotrienes that are formed. You have E4, which is mildly bronchoconstricting, and then D4, which really has nothing to do with bronchoconstriction. So when we talk about drugs in this class, we're either going to block the formation of leukotrienes, or we're just going to block the receptors that they work on. And so that's exactly what this picture is going to show. So from arachidonic acid, you have your leukotrienes that are formed, which are potent vasoconstrictors, and then your subtypes, which stem off of that. So with some of our drugs, which is Xyluten, is the only drug in this class, you're going to have direct 5 lipooxygenase leukotriene inhibitors. So 5-lipooxygenase is the enzyme that breaks down arachidonic acid to leukotrienes. So you're going to inhibit the enzyme. So with that enzyme inhibition, you're decreasing the concentration of leukotrienes. And then the nice thing with this drug is you're decreasing all the subtype concentrations. With the receptor antagonists, we only have drugs that will antagonize the receptors of the subtype D4. Remember, C4 is also potent, but we have no drugs that target that leukotriene. Only D4 receptor antagonists. And this is your montelukast and zarfalukast. Okay, so this is the slide showing you how the drugs break up, and then there's your mechanism slide. Adverse effects of these drugs, you see quite a bit of hepatotoxicity, mostly associated with Xyluten, not the other 2 medications. And you do see pretty predominantly headache and GI disturbances are what cause patients not to want to take these long term. In the United States, these drugs are only available orally. Okay, if you look at, in Europe, they're available intravenously, and so their algorithms are a little bit different when they have patients that come in extremis, but for our purposes, they're only available orally. And there really has not been a place for these agents in patients coming in with acute asthma exacerbations. It's really for patients who have to have maintenance therapy. You don't need to memorize the isoenzymes, but do recognize that these agents are hepatically metabolized, and it can lead to a number of drug-drug interactions with 2C9 and 3A4 inhibitors, inducers, and so forth. Clinical uses, again, already mentioned. It's really maintenance therapy, prophylaxis for allergen or exercise-induced allergy. And then patients who have asthma-induced aspirin, this actually, if they have a compelling indication to get aspirin and they can't tolerate other antiplatelet agents, you can give patients drugs from this class because, again, if you look at the pathway, it's the arachidonic pathway where these leukotrienes are coming from. So if patients have a true allergy to aspirin, not that they just get a GI upset, but they get a true allergen IgE-mediated reaction to aspirin and have a compelling indication, you can give them these drugs and it'll help block that allergy. Okay, and the last now is our immune globulin antagonist, of which there is only one on the market. This drug is a unique mechanism in which it inhibits IgE from binding to the receptors on the mast cells. So in somebody who is exposed to allergens, those IgEs are increase in levels, hits those mast cells, causes them to break up, and releases those inflammatory cells and mediators. So this drug really stabilizes that mast cell from IgG, from breaking it up. It is administered subcutaneously. Adverse reactions are, of course, just bruising at or local injection sites, pain, and so forth. But it is extremely expensive, and the clinical utility of this drug is really limited to only patients who have severe asthma and have tried every class of medication. There is some patients who will respond to this class, but it is reserved for patients who have severe forms of asthma, who have tried every medication, and now you're at your last wit, and you're going to try this in them. So in summary, what we talked about is there's several different classes of medications for asthma. Drug therapy is dependent on the severity of symptoms, but remember, in patients with persistent asthma, so somebody, it can be mild, moderate, or severe, but it's persistent, you have to treat them with an anti-inflammatory. And the anti-inflammatory of choice is a corticosteroid. Okay? And depending on their severity will depend on the dose of the corticosteroid. Only patients with intermittent asthma can be managed with a short-acting beta agonist. But all other agents with persistent asthma should have an anti-inflammatory, again, the choice being an inhaled corticosteroid. However, no matter if you have intermittent or persistent asthma, every patient needs access to a short-acting beta-2 adrenergic agonist. Why? Because every patient has the probability of having an acute exacerbation. And even if you have persistent asthma, the drugs that you're on for maintenance therapy are not the drugs you're going to want to reach for if you have an acute exacerbation. So every patient with asthma should have access to a short-acting beta-2 agonist in the event they have an acute exacerbation. You do not need to memorize this slide. This is kind of just to put everything in context. I have been talking about intermittent, and then there's the persistent, mild, moderate, and severe. And this gives you context, and I have a couple cases that you'll work on, which will, because you have to diagnose somebody in one of the cases, and you'll need this chart. You will not be asked for testing purposes to ever diagnose somebody of whether they're persistent or intermittent, okay? But this is what you would do if somebody came to you with asthma. And then you would classify them of if they're controlled, if they're not well controlled, or very poorly controlled. Because ultimately, the way we approach asthma, and you don't need to memorize this, but you guys should already know the concepts of this and understand things. The way we talk about asthma is it's called the step-up therapy. So when somebody is not well controlled in their step, you step them up. Once they get controlled, you try to step them back down. Why? Because you always want to use the lowest possible dose that is going to control their asthma. So if they're not well controlled, you step them up. Once they are controlled, then you go back down a step to see if they can maintain their control. So look at step 1. Step 1 are for patients with intermittent asthma. Remember, that is the only group of patients that can be controlled with only a short-acting beta agonist. Then you have all of your persistence. And you see here, you're going to start, what's the first therapy on here? ICS is inhaled corticosteroid. You're going to start with a low-dose inhaled corticosteroid. Why? The underlying problem of asthma is inflammation. So you need to treat the underlying disease. And look at as you step up, you're just going from low dose, medium dose, to high dose of inhaled corticosteroid. That is your backbone of therapy. Now, all these other things, again, you don't need to memorize this, but you can see that the other drugs like theophylline are kind of last line or after you've tried all these things or patients are failing things. Your backbone are inhaled corticosteroids. And you can see that the one immune globulin or immune modulator is all the way at the end for step 6 when patients have failed all other types of therapies. Quick relief medications for all patients. So no matter what step you're in, what category you're in, you need to have access to a short-acting beta agonist. Okay, so this is like a test question. Let's see how you guys do. Which orally administered drug blocks leukotriene receptors? Theophylline, tiotropium, prednisone, montelukast. See, you guys are ready. Now you just have to remember it for 2 weeks. Okay, another one. Which drug inhibits the degradation of cyclic AMP? Theophylline, tiotropium, prednisone, or montelukast? A little bit less. How about, who says A? B, C, D. Okay, we got to do a little bit more study. Remember, this is cyclic AMP degradation. So what is theophylline? It is a phosphodiesterase inhibitor. We're inhibiting the enzyme that breaks down cyclic AMP. We're going to plow through. We're just going to get through this section, then I'll give you guys a break. So COPD. Similar to asthma in some aspects, but the problem with COPD is that the airflow limitation that you see with this disease is not reversible. So where we said with asthma we have all these inflammatory markers, mucus production, we can reverse that. We can't with COPD. And the drugs that we have available to treat symptoms or hold people at bay does not reverse the disease process. We can reverse it with asthma, we can't with COPD. And the number one cause of COPD is what? Smoking. So the one way we can help prevent disease progression is by adding on smoking cessation. But once somebody's reached a category of COPD, we cannot reverse that. So our goals are going to prevent disease progression, relieve current symptoms, decrease hospitalizations and exacerbations, and of course get people to quit smoking. Long-term management of patients with COPD can be the use of oxygen. You can use regular treatment with one or more bronchodilators. So when you look at the COPD guidelines, they are not specific as to what bronchodilator. They just say one or more bronchodilator. As I mentioned earlier, what's the most common bronchodilator for COPD? Anticholinergics, right? So we tend to use more ipratropium, more tiotropium in our COPD patients. So we tend to use anticholinergics as the bronchodilator of choice. But you could use albuterol. You could use a beta agonist as well.
Can you use it by itself in COPD?
Can you use it? Yes. So the anticholinergics can be used by itself in COPD, where we said earlier with asthma, we would only use it in exacerbation in combination with beta agonists. With COPD, you can use bronchodilators alone. And then if patients progress and they don't have a good response to the bronchodilators, you can use inhaled corticosteroids. You may progress to parenteral corticosteroids as well. It's just like asthma. You want to start always with inhaled and only go up to parenteral once they fail the inhaled or they don't have the same response. For acute exacerbations, here again, you're going to use just short-acting bronchodilators, kind of the same concepts with asthma. More likely, you're going to use a nebulization when somebody's an extremis versus handing them a metered-dose inhaler and hoping that they do it right. And the other difference with COPD exacerbation is most of the time, exacerbations are caused because of an infection. And so the role of antibiotics in the use of treating a COPD exacerbation has much more substance than treating somebody with an asthma exacerbation with antibiotics. Again, you should still have some sort of clinical need, whether they have chest x-ray findings, sputum production. If they get mechanically ventilated, that is a trigger right to start antibiotics. But antibiotics do have a role because patients coming in with a COPD exacerbation likely have some sort of infection. Now, it can be bacterial, it can be viral. Viral, of course, antimicrobials, you can give all that you want. You're not going to treat that infection. And so this is just pictorially how you would treat somebody, starting from mild case of COPD to very severe. You would start off with smoking cessation, PRN, bronchodilators, up to corticosteroids, oxygen, and if they're fortunate enough to be candidates for surgery, they could get transplanted. As mentioned, bronchodilator medications, we can give them on an as-needed basis or a routine basis, depending on how severe their disease is. So just like with asthma, it's kind of that step-up approach, but with COPD, you don't step down. Okay? You don't improve. Nothing's reversible. So once you've stepped up, you step up. Again, the guidelines for COPD don't say what to use first. They just say bronchodilator. So you're at your choice for choosing all of the therapies that are up there. But again, with COPD, we're mostly going to use anticholinergics. And of course, just like everything else, inhaled is the preferred route, decreasing side effects. Question?
So once you stepped up, you step up. That if you step up during exacerbation, you don't.
This is just stable.
Okay.
We're just on stable COPD. So once you stepped up in somebody that's stable, of course, an exacerbation, you would probably just give them like a pulse of something, and then it would go away. And then corticosteroids, regular treatment with inhaled corticosteroids can be added on to patients who aren't responding to the bronchodilators. These do become problematic in this patient population because it does increase the risk for pneumonia, even when you have inhaled corticosteroids. And then corticosteroids combined with long-acting beta-2 agonists is superior than any agent alone. And I think we've talked about that because what do steroids do to your beta-2 receptors? Do they increase the sensitivity or decrease it? Increase it, yeah. Yeah, so we're using those as combined is superior than just using either one alone for this patient population. Okay, so now we'll talk about smoking cessation and the different agents that are used. I don't need to read off these statistics for you, but essentially what happens with nicotine is it activates those dopaminergic centers in our brain, and it can happen very rapidly, 11 seconds. And we get that sense with dopamine, we feel good, we have positive reinforcement, but the problem is that we want to sustain that effect, and so that's how patients tend to smoke more cigarettes because they build up a tolerance over time. They want the same effect. They want it sustained over a long period of time. After quitting smoking, you can start seeing effects 20 minutes after nicotine levels have declined, and that's improvement in cardiovascular parameters such as heart rate and blood pressure. All the way out to, so you can see weeks, only 2 weeks, you see 30% improvement in lung function. And then you get out to years, you decrease by 1/2 your risk for MI, and out to 15 years you can see decreases in stroke and MI. So you can see there's a lot of importance to having patients stop smoking. Nope. We're done. There we go. When initiating drug therapy, it's important to set a quit date. It's important to set a quit date. It's important to set a quit date. So you can give all the drug therapy in the world. If you don't give that patient something that's tangible, this is what we're going to stop, nothing is going to work. So the first thing that you need to do with smoking cessation is say, what is our goal? What are we going to do? Let's put this on the calendar. Here's the day we're going to stop. And then we can use therapies to help the patient along. And oftentimes the therapy is going to be based on, it's not going to be based on clinical evidence. It's going to be based on patient preference. Maybe somebody else in the family quit a year ago and they used this. And so that patient coming in is going to want to use that because that patient quit and they were successful. There are some underlying comorbidities that patients may have where it's going to limit the drugs that we can use, and we'll talk about that with the individual agents. But for the most part, it's going to be clinician familiarity or it's going to be patients who are preferring one agent over another. So our first-line medications, there's 3 classes. We can give nicotine replacement therapy. We can give a antidepressant, specifically bupropion, and then we have varenicline, which is one of the newer agents. So with nicotine replacements, we are controlling nicotine levels in the bloodstream so that withdrawal doesn't occur. And so the whole theory is that you want to maintain the nice level of dopamine, but slowly decrease it over time with nicotine replacements. And there's 4 different types of replacements we can use. The first is gum. And gum is pretty easy to use. It satisfies the oral craving because oftentimes with smokers that still is their hand-to-mouth motion. So with putting the gum in, it can reduce weight loss because you're doing something with your hands and your mouth instead of eating food now as opposed to smoking. So it has been associated with delay of that weight gain. And then patients can titrate. But it's important to talk to them that they don't use more than what they were smoking. So you have to give them a max amount of gum pieces that they can use in a day. But then you slowly start taking those pieces as time goes on to get to your quit date. Okay. Obviously, there's problems with gum. If people have jaw problems, dental work, or other reasons they can't have sticky stuff in their mouth, you do need to have proper chewing technique. It's a chew and park. If you just keep chewing, you're going to deplete all the nicotine out of the gum, and then you're pretty much done with it in 5 minutes. So you need to chew, park, and it is a technique. And lastly is that you can't eat or drink anything too hot or too cold around the gum. Too hot, you're going to be vasodilated, you're going to get all the nicotine out of the gum. Too cold, you're vasoconstricted, you're not going to get any absorption of the nicotine. So there are some things that you have to work around with the gum.
I'm just curious, I understand how nicotine might have cardiovascular side effects, but does nicotine itself play any role in the causes of cancer or any other comorbidities associated with smoking?
Oh, sure. There's carcinogens within the tobacco itself that when inhaled directly into the lungs definitely leads to lung cancer.
And then, as a gum, so not smoking.
Oh, no. No, ingesting nicotine in and of itself, to my knowledge, has no cancer risk. It's the carcinogens that are in the act of smoking, yeah. Yeah.
Doesn't long-term use cause mouth cancer though, and cause stomach cancer too?
Again, I don't know if it's the nicotine itself or it's the carcinogens that's within the smoking of it. I can look and get back to you guys. I honestly don't know. I can get back to you. Yes?
So obviously the end goal is the quit date, somebody would stop smoking, but what for patients that have difficulty in reaching that goal, what would stop you from continuing to prescribe that and just having a replacement therapy?
That's a good question. I mean, it's going to be an expense. It's going to be it's much more expensive to do the nicotine replacement than it is with cigarettes. So we can talk about. Okay. Next one is the lozenge. Same thing, it satisfies those oral cravings, and it's easy to use, easy to conceal in the mouth. You don't have to chew. And patients can titrate therapy. Again, you start them off at a dose and then slowly titrate down. With lozenges, though, you can see more GI effects with these agents, which can be quite bothersome, heartburn to patients. And you cannot chew. You do really have to, the lozenger has to dissolve in your mouth, and you cannot chew it or break it up. Otherwise, again, you're not really getting the benefits of having that long-lasting effect of the lozenge in your mouth. Again, the same eating, drinking, hot, cold agents between lozenges applies. Some patients will like the patch. It's easy to conceal. It lasts for 24 hours, so you don't have to worry about carrying around anything with you. And you don't have compliance issues. You don't have to worry about taking gum or using a lozenge every so many hours. Again, you're getting that 24-hour steady state of nicotine. However, you can't titrate the patches as well as you can the gum and the lozenge. So there are only about 3 or 4 fixed doses of the patches. So you'll go from a substantial amount of milligrams, something like 14 milligrams, down to 7 milligrams. And there's no in between. You can't cut the patches or quarter them and put them on. So the ability to titrate is a little bit different with the patches. Some patients might have allergic reactions to the adhesive, and so that may prohibit their use. Or if you have a dermatologic condition, especially with open wounds, you wouldn't want to put a nicotine patch on that because you'll just get more absorption. And then finally, the nicotine inhaler. Again, you can titrate with the inhaler, and this more mimics that hand-to-mouth motion with using nicotine. Problems, though, are patients who have underlying COPD or asthma exacerbations. It may cause bronchoconstriction and bronchospastic stuff. And you may, because you are inhaling a powder, cause some throat or esophagus irritation. Now, who can you not use nicotine replacement therapies in? These will be patients who are immediate post-MI. So within a 2-week period of somebody having an MI, you cannot use the nicotine replacement therapies, again, because you'll see the cardiovascular effects still of nicotine, the heart rate, and so forth, which you need to control with an MI. Those patients who have serious arrhythmias should not use this, or with serious or worsening angina. The next agent, which you'll hear more about next week as an antidepressant, is bupropion. It's marketed under different brand names for the different conditions. So the drug company was really smart. It was originally marketed as an antidepressant under Wellbutrin, and they found that it actually had a niche as smoking cessation because it works on inhibiting the reuptake of dopamine. And so they found that it worked in patients trying to quit smoking, because that's the mechanism behind why patients continue to smoke in some cases, is that dopamine. So you're going to inhibit that reuptake with this drug. And so then they got a longer patent and they marketed under Wellbutrin. Zyban. It can be used in combination with nicotine replacement therapy. In fact, it's oftentimes recommended to do so because, again, you're going to start this drug and then you may use nicotine therapy, then wean off the nicotine therapy, and then continue using the drug. Again, setting that set date so that you're starting the drug knowing you're going to take this drug out to the quit date. It might be funny, but if you also have a depressed patient, this might be the optimal treatment in a smoker who's trying to quit, who also has some depression. You'll essentially kill 2 birds with 1 stone. It is well tolerated in patients with cardiovascular disease. So minus the nicotine replacement therapy, bupropion can be used in patients with cardiovascular problems. It cannot be used in patients with seizure disorders, though. The abrupt withdrawal and the potential for lowering the seizure threshold with this medication, it's not recommended to use in these patients. Now, obviously, somebody with active seizures or uncontrolled seizures, it is an absolute no. In somebody who is well controlled, you may be able to get away with using this drug, but there is caution behind this. So somebody with a seizure disorder should not use this. And then finally, this particular antidepressant, again, you'll learn a lot about this next week. A lot of antidepressants cause weight gain. This particular antidepressant delays weight gain, or you don't get that same weight gain. So again, for depressed patients, this oftentimes is the drug of choice because of that. And then the last drug, varenicline, is a different mechanism of action. It's selective for the nicotine receptor, so it acts as a partial agonist at the nicotine receptor, again, expressing that dopamine and having those effects. It's not a full agonist, so it's only partial, so you're only seeing some of those effects. The initial enthusiasm for this drug was tempered by when we saw the side effects that occurred in patients who were receiving this drug. And there's a black box warning noting severe psychiatric reactions to this, including changes in behavior, agitation, and as far as suicidal ideation. So it's very important, the drug is still on the market, but to monitor patients when they're started on this, to get them into the clinic, ensure that they're not having any of these reactions, or if they have them, that they stop this medication, which can be abruptly stopped. Okay, so question, what is the most important step to consider when initiating smoking cessation? There you go. Okay, you have a couple cases, so I'm going to give you until 6 o'clock. You can work up the cases with a partner and take a break, do whatever you want, but you have until 6 o'clock to do those things.
One about inhalers, like probably you want to rinse your mouth instead of. I realized that if you were talking about using inhalers and putting it in the question, is there any way that I could just quickly jot down
No, this is that Tori.
I have a question about the turf. You said we usually get sub Q for triple.
Yeah.
I want to give an IV.
You can give an IV also
Okay.
in like really severe cases, but I think for the majority of the part, we will send to get like sub-Q, it's like a one time, like 0.3 milligram.
Okay.
So you can hopefully use it.
Yeah.
Sorry, I don't know why I think about that.
That's okay. Okay, thanks.
Yeah.
I want to go to the gym after that. What
I'll be there though. I'll see you there. So I mean, I can't like outside of like like you want to minimize it, but really just stop it.
exciting and I went to grab it and I did the same side thing, and so I grabbed it and I grabbed it. Is that 42? Yeah.
Thank you to those who came back. Okay, so our first case that we had was a patient who came in who recently joined a fitness club to lose weight, but she never exercised before. She comes in today with new onset cough and trouble breathing. She attends this fitness class twice weekly. It doesn't limit her activity. So how many of you said she's classified as intermittent? How many said mild persistent? Mild or moderate persistent? Severe persistent? Good. Okay, everybody got the intermittent. So if you just simply go to the chart that I gave you and you look at how many times that she's having the asthma attack, which really is really directly related to exercise, it's not inhibiting any of her activity, she's not sleeping any differently, that she really is classified as intermittent. So, which one of the followings then would you want to treat knowing that she has intermittent asthma? So, how many of you said A? How many of you said B? C? D? How many of you didn't guess? Okay, so I see that some of you picked D. Because she's... you gave yourself away. So remember with intermittent, and again, this is not testing purposes. These are to massage your brains with the material that we're working on. So intermittent, you can only use, or you don't only, but patients only need a short-acting beta-2 agonist, okay? It's not until you get to the persistent, because the underlying problem is the chronic inflammation, that then you would need an inhaled corticosteroid. But since she's having intermittent, we don't have to jump to a steroid. We can just give her a short-acting albuterol inhaler, and she can use the albuterol inhaler that twice a week before she goes and does her exercise. Okay, so next we had a patient coming into the ED with short of breath, and he can't talk because he's so short of breath. He was at home and he was puffing on his albuterol inhaler without any relief. And so how many of you now want to treat RF with A? B, C, and D. Okay, so the majority of you are D. Of course, you're going to want to use a nebulizer treatment. This patient can hardly talk. He probably was using his albuterol inhaler maybe appropriately in the beginning, but then was getting more short of breath, and then that drug wasn't just getting into his lungs. He probably was then getting anxious and not able to puff and accentuate at the same time. And so we're going to use a nebulizer for this patient. And remember, we're going to try to give corticosteroids to this patient to prevent that late phase. It's not going to work immediately in 1 to 2 hours. We're going to prevent that late phase asthma exacerbation. Lots of words. This patient is coming into the ICU for respiratory failure from a COPD exacerbation. She was recently prescribed 40 milligrams of prednisone. She has anaphylaxis to penicillin. You see her blood pressure and so forth. She's intubated. And so how are you going to treat the severe COPD exacerbation? So question A, or answer A, B, C, and D. Okay, so we're a little split between C and D. So I have to go back to what C is. So 1 mg per kg of methylprednisolone is a lot. You guys, I didn't give you doses, but that's a lot of methylprednisolone. So the standard for a COPD exacerbation is 40 milligrams of prednisone or equivalent. So that's why answer D is more appropriate than C. Answers A and B were inappropriate mostly because anaphylaxis to penicillin and there was unison written. So remember, with COPD, we're more likely to use an antimicrobial, especially with somebody with secretions or a real reason to have, or these patients oftentimes have infections because of their exacerbations. So a little unfair because I didn't give you the doses, but good for this.
What's the max that you would see? I've had IV Clymidrol 60.
Yeah.
So why would that be so?
Because there's studies that show that prednisone 40 or equivalent are just equally efficacious than the higher doses.
Okay, so you would never go above 40.
I don't want to say never, because people are going to do it, but the standard is 40. Okay? Okay. So next we're going to go on to endocrine, where we're going to talk about diabetes management, patients who have thyroid disorders. I hate to be one of those teachers, but is there something I'm missing? Okay. And then finally, adrenal insufficiency. So just to review quickly with the pancreatic hormones. So from the alpha cells in the pancreas, they will secrete glucagon. And glucagon will increase hepatic glucose output and increase blood glucose concentrations. Now, for everything that you have a reaction for, you have an equal and opposite reaction. So your beta cells of your pancreas will promote the uptake, utilization, and storage of that glucose, and it will lower plasma glucose concentrations. Okay? So we have really 2 hormones that are secreted by the pancreas, one increasing glucose concentrations and the other lowering it. We're really going to focus on the insulin component of your pancreatic enzymes. And it's important to understand how insulin is normally secreted. So we secrete insulin in 2 ways. One is small amounts of insulin is secreted throughout the day. And that's what we would call your basal insulin. So you always have some insulin around. And then we have our, what you would say, bolus insulin. And that is secreted in response to sugars, and they can be complex sugars or simple sugars, but your insulin levels are going to exponentially increase. To keep things simple, in general, it's about 50-50. You have about 50% secreted as a as a basal rate over the day, and then 50% as boluses over the course of the day. Some people will argue and say it's 70-30, 60-40. 50-50 is a fine number as well. So if you look at a picture, this is what it would look like. Your basal insulin, again, secreted low levels throughout the day, and then in response to your glucose intake in your meals, depending on how, if you ate 5 sandwiches here and a few strawberries here, your level of insulin will increase as your body is only responding into what you take in. Okay. In general, again, you don't need to memorize these numbers, but your basal insulin, the adult secretes about 1 unit of insulin per hour. And again, it's regardless of food intake. So you're always going to have that basal amount. And then your bolus insulin, it can also be called pre-meal, mealtime, or prandial, or nutritional insulin. And again, larger amounts or smaller amounts are going to be excreted depending on how large your glucose load is. So this is an important mechanism to understand. This is how insulin is secreted. A lot of our medication, or some medications that we'll talk about, and to increase our amount of insulin excreted, we'll come back to this mechanism because we're going to play off of how our body normally works. So essentially what you have here is, I stole this from the internet, didn't want to suffer through another drawing of my pancreatic beta cell. But it's not any better. So what you have here is you have these ATP-sensitive potassium channels that really determine the resting potential of this, let's say, beta pancreatic cell. What happens is you take in glucose, this is your blood periphery. Glucose is taken into the pancreatic beta cell by these GLUT2 receptors. That changes things around, and it really activates these ATP potassium channels, and they become blocked, and it causes a depolarization of this membrane. It then leads to this influx of calcium into the cell, and then that induces the secretion of insulin into the periphery to counteract that glucose. So glucose comes in, blocks the ATP-sensitive potassium, depolarizes the cell membrane, increase of calcium causes the release of insulin. So your insulin is normally stored here in your pancreatic cells, beta cells, but they're really only opened and the insulin is excreted, small amounts during the day, but really you see those bolus doses in response to all this glucose in the periphery. So diabetes happens when you have insulin secretion that is either not sufficient to overcome the needs of the body, or it doesn't have the same activity level. And there's different types of diabetes. There is type 1, and I have in parentheses the old terminology. So some of you may or may not be familiar with calling somebody an insulin-dependent diabetic, or it was also abbreviated as IDDM. That is old terminology. You refer to somebody who has beta cell destruction and an absolute lack of insulin as a type 1 diabetic. And I'll explain why the old terminology doesn't exist anymore. So type 1 has an absolute lack of insulin. So they need insulin in order to survive. Your type 2 diabetics have a relative lack of insulin. So they may have some destruction of their beta cells, not complete. They may not secrete as much insulin, or the insulin they secrete is not working the way that it should. And again, old terminology was non-insulin dependent diabetics, or abbreviated as NIDDM. Now, the reason why that became kind of not a good terminology anymore is because we treat today a lot of type 2 diabetics with insulin. Some type 2 diabetics, depending on the severity of their diabetes, have to be treated with insulin. There's no way you will get them under control with other medications. And so to say somebody is insulin dependent, it does imply that they need it to live, but some type 2s are still dependent on that insulin because they have such severe type 2 diabetes. If they didn't have their insulin, it doesn't mean they'll die. Like type 1s will die without insulin. So that's why because we tend to go to insulin a lot sooner in all types of diabetics, especially type 2, we don't want to use the terminology of insulin dependent or non-dependent. So that's why they're type 1 and type 2. Then there's gestational, so that's the onset, or you find out somebody has diabetes during pregnancy. Typically, after baby's born, the diabetes will go away. And then you also have secondary causes, so patients with pancreatic cancers or tumors, cystic fibrosis, endocrinopathies, or patients who have had drugs and chemicals. So I don't if you remember last week, I'm not sure if Dr. Greco talked about like certain drugs, polymyxin, pentamidine, can cause destruction of beta cells. And you can cause somebody to lose those beta cells over time and essentially induce a type 1 diabetic. Many veterans out there were exposed to Agent Orange during the Vietnam War, and those patients are also diabetics and oftentimes type 1 because they had complete destruction of their beta cells. There's a number of other medications outside of antimicrobials. We already talked about earlier. Steroids can induce hyperglycemia. There are some of your HIV meds. There are some antidepressants. You don't need to memorize this list. But be conscientious that if somebody comes in with new onset diabetes, otherwise a healthy person, take a look at their med list because there might be something on there that induced diabetes. We talked very early on in class thiazide diuretics. We talked about how they kind of have fallen off, or they're not the number one. They're kind of with an or now next to them because of new onset diabetes with thiazides. You don't need to memorize these goals, but you do need to set a goal for diabetic patients, and these goals have been set. Because once you get that hemoglobin A1C down to about 6.5 to 7, you stop seeing those heart attacks or the kidney disease that's associated with diabetes. So we want to get those down to that goal. You also want to see a fasting glucose between 70 and 130. And after patients eat, you want to keep that glucose below 180. Not only do you have glucose monitoring, but you got to make sure their blood pressure, their triglycerides, cholesterol, and all of that is also under control. Because in aggregate, if we can control their blood pressure, control their lipids, control their sugars, we'll have better outcomes for the patients. Less kidney disease, less heart disease, less eye disease, less neuropathies, and so forth. Long laundry list. So we got to get through all these medication classes, but we're going to have fun doing it. Okay, yes, deep breath. All right, insulin. So insulin's obviously the number one agent that most diabetics will use. It does come in different preparations, so we can get those from animals. It's not really prescribed much anymore. There are a certain group of patients that are still maintained on animal insulin. However, because of the number of the side effects that are seen, including the number one of immunogenicity, because it's not your own, it's recognized as something else, we really don't prescribe that anymore. And we do have the human insulin, which is produced from recombinant DNA technology. Insulin is a peptide hormone, and we can't yet today, in 2015, take it orally because it's so rapidly degraded by our enzymes. We will see that we can take it inhaled. So about a year ago, a device came out that we can inhale insulin. But up until that point, we really were only giving insulin parenterally. It's the drug of choice. It has to be the drug of choice in patients with type 1 diabetes. Patients with type 1 diabetes have an absolute deficiency of insulin. They need insulin to survive, so you have to use insulin in order to keep these patients alive. It can be used in type 2 diabetics, as I mentioned, in patients who are poorly controlled, in patients where other medications have failed. Newly diagnosed type 2 diabetics should also get insulin, especially if they have severe hyperglycemia where they're admitted to the hospital, sometimes with diabetic ketoacidosis, and then diabetes of pregnancy. Now, this is where you're going to want to focus your efforts. We have different preparations of insulin and different administrations. So we're going to have 4 different classes of insulin, and it's going to be real important to understand what are some of those differences between them. And the biggest one is going to be their onset of action. So we have 3 different preparations of rapid-acting insulin. This type of insulin works in about 15 to 30 minutes. When you take rapid-acting insulin, because it works so fast, it is recommended to take this insulin right before a meal. So you know you're going to eat, you take your insulin, you can eat your meal. And that's really how you want to think about rapid-acting insulin. It works fast. No, I'm not going to say 15 to 30 minutes or 30 to 45 minutes. I'm not going to give you the nitty-gritty, but you should understand it works the fastest. It can be taken right before a meal or right while you're eating during a meal. And look at its duration. Its duration is only about 3 to 4 hours. So really this is mimicking our bolus insulin, if you will. It has a rapid onset, and then it has a short duration of action. And it's going to peak, and it's going to come down. So it's really mimicking our endogenous insulin, that would be our bolus, or our prandial, or our meal insulin. It can be administered subcutaneously, or it can be administered intravenously. So rapid-acting insulin can be given sub-Q or IV. It is clear and should always be clear. If you pick up a vial of rapid-acting insulin and there's particulate matter or it's cloudy, discard. It should always be clear. You have one short-acting insulin left on the market. Its onset is 30 minutes. So now we're getting on to a little bit longer in onset. Our duration is going to be 4 to 6 hours. So now we kind of have this peak effect, but a little bit longer hump in the peak. But still, short-acting insulin is mimicking still what would be our bolus endogenous insulin. You want to give or take short-acting insulin about 30 to 45 minutes before mealtime. Okay, because it takes a little longer to work. You don't want to take it with the meal. You want to take it about 30 to 45 minutes before the meal. So that's one real big difference between rapid and short-acting, is in relation to meals when you take these insulins. And it all goes back to when it starts working. Short-acting insulin can be administered subcutaneously or intravenously. It can be administered subcutaneously or intravenously. Short-acting insulin should also look clear. If you see particulate matter or cloudiness, discard. Should always be clear. You have 2 intermediate-acting insulins. Now our onset's getting longer. These agents are going to start working about 2 to 4 hours and last about 8 to 12. So what type of insulin is this mimicking? A little bit closer to our basal insulin, okay? Not so much our peak. It's still going to have a hump. It's not going to be flat like our basal. We're still going to see a little peak and then come down. This insulin can only be given subcutaneously. Intermediate-acting insulin should never be given intravenously. It does not act fast enough. You should never give intermediate insulin IV. It should always be given sub-Q. It takes too long to act to treat anything intravenously. And it is a cloudy insulin. So if you pick up intermediate insulin and it's cloudy, you can use it. This is the only insulin that is cloudy. And then finally, you have 2 long-acting insulins. Again, look at your onsets and your durations of these insulin. Now we're going out to almost 24 hours with our long-acting insulin. So these insulin, our long-acting insulins, are mimicking our basal rate of insulin. Now there's some differences between glargine and detamers, and that glargine does not have a peak. So the way they market glargine is that it is the most closest insulin that's the same to our endogenous insulin because it doesn't have a peak. I mean, initially you'll see a little slope up, but then it's a flat line across. It does not have a peak. And both of these long-acting insulins can be given subcutaneously. They should not be given IV. And these insulins are clear. So you have one cloudy insulin, so that's your intermediate. The rest of your insulins are clear. So in summary, your rapid and your short-acting insulins are covering your meal intake and covering elevated glucose levels. These insulins are mimicking bolus or mealtime. That's the same thing. Bolus or basal. Thank you. Okay, well, you got it right. You have a 100% chance of getting it right. So, right, this is mimicking what our bolus or our mealtime insulin would look like. Okay. Our Our intermediate and our long-acting insulins are used for our basal insulin needs, and they're not intended to cover meals. They're intended, remember, our body does secrete insulin throughout the day, even if we don't have any intake of sugars. And so this is keeping us at that basal level, and we use our rapids and our shorts for our bolus. So it would make sense that we use two different types of insulins throughout the day. We're going to use a long or an intermediate acting insulin to mimic that basal, and we're going to use a rapid or a short to mimic our bolus insulin. Now this comes straight out of your textbook. For those of you who have it, you can see as you go from rapid acting insulin to long acting insulin, your peaks start getting smaller and smaller, and your duration of action start getting longer and longer. So again, understand these concepts. I'm not going to give you numbers on the exam, and you don't have to know specifically that for 45 minutes, this type of insulin. But you should understand those concepts. When given an insulin, you should know, is it intermediate, long, short, or rapid? Now, the duration of insulin can be prolonged in both patients with renal dysfunction and hepatic dysfunction. Insulin is 100% excreted by the kidneys. Insulin is 100% excreted by the kidneys when you give it exogenously. So in patients with renal dysfunction, it's going to accumulate, and those patients will need far less dose, that is high dose, as a patient who has normal renal function. So you do need to adjust insulin doses in patients with renal disease. Now, with hepatic failure, it doesn't necessarily have anything to do with the drug. It has to do with the functioning of the liver. What does the liver do? The liver stores, utilizes, and then puts out glucose. But when you start having liver dysfunction, you stop that process of gluconeogenesis. So those patients might not need as much insulin because they don't have the same amount of gluconeogenesis. So we talked about the combination products. It makes sense to use both an intermediate or a long-acting insulin in combination with a short or rapid-acting insulin. And so companies have marketed these agents. Again, you don't need to memorize this, but I would understand the concepts. So Novolin or Humulin 70/30 is 70% NPH, 30% regular insulin. Why did they do this? Well, think about how many injections you would have to take. If I gave you a rapid-acting insulin and an intermediate-acting insulin, how many injections? Just see if you guys can figure it out. At minimum 4, but it would be about 5, right? Because intermediate would be about 12 hours. So you need your basal. You're going to do 2 injections here. And then you have your bolus, and that's at least you eat 3 meals a day. So that's at minimum 5 injections that you have to give yourself. So it makes sense to have combination products that incorporate about 70, and again, this is that some people will say you're 70-30 a basal bolus versus 50-50, 60-40, blah, blah, blah. So for Humulin, you have 70-30. So you would give 2 injections, okay? You would give 1 in the morning, and that you would have your basal insulin from the NPH component, and NPH is your intermediate-acting insulin. You would also get some rapid-acting insulin, short-acting insulin on board. That's your regular insulin, and that would cover your breakfast time. Now, you're going to scale by a little bit in your lunchtime, a little bit afterwards for your kind of dinner time, if you will. You're going to take that second injection, you're going to get dinner coverage, and then you're going to get your basal until the next morning. Okay? So this is why we have those combination products. Now, there's other Novolog products, and why I bring this to your attention because this can get confusing sometimes. Because some student will look this up and say, but Amy, I found this product that is 70-30, 70 aspart protamine suspension, and 30% aspart. You said aspart was a rapid-acting insulin, so why would everything be rapid-acting in this? Well, what they do, drug companies, is they take aspart and they take protamine. And so what you do is you have a protamine molecule, and then you have all these aspart molecules that are stuck to the protamine. So it becomes, they take a rapid-acting insulin and they make it intermediate because the particles are stuck. So once you inject that drug, you have 30% of the asparts that are not adhered to the protamine, and those are working rapidly. And then over time, that protamine starts dissolving and the aspartate starts getting eliminated, and that's what makes it a long or an intermediate acting drug. Okay? So in summary, the purpose of combination products are to take either a rapid or short-acting insulin and an intermediate or long-acting insulin and combine them together to limit the amount of injections. Advantages, obviously, I just said, fewer injections, less calculations by the patient, so they're not thinking to themselves on their 4th injection, is this the 5 unit, is this the 15 unit? They'll get lost during the day. You do it generally as a standardized approach, which leads to some of the downsides, is that it is a fixed dose, essentially. You are getting 70% of one drug, 30% of another. If you need to make adjustments to that percentage, you can't do that with these drugs. You can make adjustments to the dose, but you're always going to have 70% of one and 30% of another. So how do you start? So you're faced with a patient who has diabetes, and you think to yourself, I don't know where to even start dosing. You don't need to memorize this, but there is a per weight calculation that you can come up with. You start with it based on body weight, and then you really rely on the patient to keep a good diary of events. That they're going to check their blood glucose throughout the day, they're going to come into your office with a diary, and you're going to see, well, they had a little bit higher glucose at nighttime, so I need to increase that dose, or it was more in the morning time, they got low blood glucose, so I need to lower the evening insulin and so forth. So you need to make those adjustments based on the patient, because not everybody's going to be the same, and you can't have the same prescription or the same dose for everybody. People eat different meals at different times. Those that work the night shift might have different meal times than those that work the day shift. Oh, this is the dose of total daily insulin. Good question. So you would calculate the total dose, and then if you're a 50-50, 60-40, 70-30 believer, that's how you would break it up. You would say, I'm going to take that total dose, 70%, I'm going to give as an intermediate long-acting, and then 30% is a rapid short-acting, or 60-40, as said, different believers. Some dosing pearls. Every unit of insulin will decrease your blood glucose by about 50 to 100, so that's a general rule that you can use when you're adjusting insulin. You always want to start low and go up, okay? Unless there's a patient who's dying and they're in the hospital for DKA, you need to be very aggressive with those patients. But if you want to really prevent hypoglycemia in patients, so if you're trying to work out that dose adjustment and for the next week to week and a half, they're still not at goal blood glucose, that's okay. Take your time getting there. You don't want to get hypoglycemia. At least wait 24 hours before adjusting a dose, because you need to see how a patient is going to react to that dose. Making any changes sooner, you're just not going to be able to anticipate how the patient will respond. And then finally, in type 1 diabetics, insulin should never be withheld. Even if they are hypoglycemic, you just increase their dextrose content. You do not hold insulin in a type 1 diabetic. Those are patients that have an absolute deficiency. You never hold the insulin. You lower it to a very, very low dose. You just give them more dextrose. In summary, for our administration, only sub-Q, all insulins can be given sub-Q. There are no restrictions on that. Where you want to inject, preferentially the abdomen, the butt, the arms, and the legs. That's kind of how it goes. And you want to make sure that the patient is rotating the site and not using the same site every day for a prolonged period of time, because you'll get a little fat deposit in that area and you'll decrease the absorption of insulin. You also want to make sure the patient understands that, they give an injection, oh, it hurts, and they're going to walk around like this. Well, you've accelerated the absorption of that insulin when you start vasodilating that area, when you're pressing it down, creating heat, or exercising right after. Especially those agents that use those protamine molecules, you will break down those protamine molecules with any type of heat or vasodilation. So then all of that insulin that you gave became rapid acting very quickly. There's There's syringe and vial, which is the most common. There's pens, insulin infusions. We'll talk about those in the next few slides. And then for IV administration, only short and rapid-acting insulin can be given IV. So our pens actually, when they came out of the market, really increased compliance to patients who had to take insulin. So again, patients with, generally all we had in the past was a vial of insulin and a syringe. So people had to carry around two different things. It really wasn't always easy. You had to measure up the insulin and the tuberculin syringe and so forth. So these pens came out, and all you need to do is click it, the notches for the units that you need. The syringe is right, or the needle part is right there. You don't have to dispose of anything quickly. You can take it home. It's concealable in pockets, purses, etc. So it really increased compliance for patients. Sometimes they had to carry around two pens because they would have their intermediate acting and then their short acting pen. And they're still very available and on the outside. If you work in an institution, though, this is where the controversy has come, because guess what started happening? We shared pens with patients. So we usually had to ban the use of pens in our hospital because of that, especially when an HIV patient, then it was used in a non-HIV patient. You can imagine that stuff. Not that it happened with us, but there's a lot of reports in the literature about this. So in an institution, these are generally gone, but definitely on the outside, much improved compliance. For those patients that are very, very brittle diabetic patients, they may need an insulin pump, which is just continuous infusion of insulin. These devices are very nice. They actually sometimes have glucometers right on them so that patients can check their glucose, and they can make real-time adjustments to their insulin infusion. Sometimes if they eat a high meal, they can dial up the insulin because they know they need a little bit more and so forth. This is not used for every diabetic. These are typically, again, your very brittle diabetics, where you have to be very precise from an hourly basis on how to manage the patient's insulin. But really the insulin, the original ones used to be very, very big. Now they're small as like a little pager that hooks on. When vials or pens are not in use, they should be stored in the refrigerator. It does increase the manufacturing labeling date in terms of expiration. However, they can be kept at room temperature out for 28 days. So once you're using a pen or using a vial, you can travel with it. You can keep it at room temperature. You do need to keep it out of extremes of conditions. So not in the freezing weather and not in direct sunlight. But at room temperature, it's fine for 28 days. Again, if you keep it in the extreme, you're going to pick up a regular insulin. It's going to look cloudy. You're going to discard it and use a new one. But when not in use, it's in the refrigerator. Adverse effects. Hypoglycemia. 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 This is the number one adverse effect of insulin that we do want to prevent. Moving forward, I would suggest knowing all the agents that we talk about, do they or do they not cause hypoglycemia? Insulin causes hypoglycemia. When patients get hypoglycemic, you'll see different signs. You'll see your sympathetic system activate, where you're going to see an increase in heart rate, palpitations, sweating. You'll also see the parasympathetic system, where you see nausea and hunger as well. And then patients may progress to coma if untreated. Now remember, some of our patients, you may block those sympathetic signs because they are on a beta blocker, right. So that's why patients will still elicit the parasympathetic, but the sympathetic they may not have. So those patients that are on beta blockers and have diabetes need to make sure you counsel them that they may not see those same signs anymore that they used to. Insulin allergies, of course, anything in the world somebody can have an allergy to. More associated with your animal products that you'll see the allergy. And you'll also see the immune insulin resistance more commonly with the animal products. And again, that's why we just don't use them anymore, because we have the human recombinant forms of insulin. We already talked about the lipohypertrophy. Somebody injecting the insulin at the same site every time, you're going to get a little fat pad, and then you're not going to have the same absorption of insulin if you keep using that same site. So, treatment of hypoglycemia. In mild cases, in somebody who's conscious, and able to swallow, you want to give them simple sugars. So you want to give them a lifesaver to suck on, glucose tablets, juices, any sugar packets, anything that's simple. What you don't want to do is say, hey, here's a sandwich. It's a complex carbohydrate, so in about an hour you'll get the glucose that you need. They will progress onto the coma. So you want to make sure you're using a simple sugar. In patients who do not have an intact mental status, you can give if you can get an IV site, you can certainly use high concentrations of dextrose, or you can use glucagon, which can be given intramuscularly as well. You don't want to be fiddling in their mouth, dumping some sugar packets down there, because inevitably end up in their lungs and not necessarily where they need the glucose. Oftentimes, if you see somebody pass out, and you do see an insulin pump on them, or you know the person, they will have a glucagon pen usually very close by, or the syringe very close by, because they do experience these episodes of hypoglycemia, and they typically carry those around with them. So if you want to be a good Samaritan, you can rummage through their purse. If it's only one time, don't say I told you to do that. You'll probably find one in there. And as I mentioned, as of actually almost about last year, the FDA did approve this novel device for inhaled insulin. There was a product that was out, about maybe late 1999, 2000, and it failed miserably. It didn't work the way that it had said it was going to work. But this so far is on the market for a year, and it is kind of revolutionary because they have been working on administering insulin for decades other than just giving it sub-Q or IV, looking at inhalation. Nobody has yet formulated a tablet of insulin. It is a dry powder of human recombinant, again, DNA insulin. What happens is they're in these microspheres, if you will, and upon inhalation it breaks up and it becomes a rapid-acting insulin, which peaks in about 15 minutes after administration. So this is good for those patients who take a basal insulin and then they need to take rapid insulin throughout the day. These patients would be good candidates for using this type of inhaler. Dosing at the beginning of a meal or 20 minutes of starting a meal is what's recommended with this. But I think you need to also think about special patient populations and patients who have COPD or asthma or other type of bronchoconstricting type diseases. It is contraindicated in those patients because it is an irritant when inhaled. And it is also not recommended in patients that smoke. It has more to do with the metabolism of those microspheres and the nicotine from smoking. And you just don't seem to get those same levels of insulin with patients that smoke. So those are two patient populations that you cannot use this device in. Our next class of agents for diabetes are your sulfonylureas. Now, this slide should look familiar because it has a very similar mechanism of action as to what our body normally does and how insulin works. So essentially, if you remember the version of this, you had all this glucose out here, came in, blocked this channel, increased calcium, and then you had insulin release that counteracted the glucose. What sulfonylureas do is you actually have this sulfonylurea receptor on the beta pancreatic cells. So you use these drugs, sulfonylureas, to target the sulfonylurea receptor, causing closure of the ATP potassium channels, depolarizing the cell, causing that increase in calcium, causing that insulin release. So we're trying to mimic exactly what the body would do, but we're tricking the cell because we're not waiting for that glucose to come in to cause this reaction. We're targeting a receptor site to cause this reaction and cause insulin release. So patients still have insulin in their beta cells, but there's some reason that the amount of glucose doesn't matter in their periphery. They can't release this insulin. So we're fooling the beta pancreatic cell into causing closure of the ATP potassium channel, depolarizing, and so forth. We can only use the sulfonylureas in type 2 diabetics. you need insulin in order for these drugs to work. Think of their mechanism. They're causing the stored insulin to be released. In type 1 diabetics, you have no stored insulin. So you can only use these drugs in patients who have insulin, and that would be your type 2 diabetics. Now we have different generations of the sulfonylureas. Notice nothing is highlighted here. They are still on the market, but they are very, very, very infrequently used, mostly because they cause more hypoglycemia compared to the newer drugs, and they have less effectiveness as compared to second generations, which you will see some yellow on this slide. So you have three drugs. You have glyburide, glipizide, and glimepiride. What's the first striking thing you should see with these agents is that they do have prolonged duration of actions, with the majority of them about a day that they are acting. So these drugs are not frequently dosed, but once you take the drug, you will have insulin secretion. No matter what you eat or what you do during the day, this drug will cause insulin secretion. So will this lead to hypoglycemia? Yes. Because you are causing the release of insulin, and it's a release of insulin regardless of what glucose you're taking in, right? Because you're targeting a sulfonylurea receptor on the beta pancreatic cell, causing that whole cascade of events to release insulin. So these are long-acting agents. So you take this drug, and then you forget to eat breakfast, you forget to eat lunch, you forget to eat dinner, and now you're passed out. You're that person, somebody's rummaging through your bag giving you some glucagon. So again, it's important that patients who take sulfonylureas eat consistent meals or intake consistent glucose, because regardless of your intake, you have this insulin release, and it's all day long. It's not short-acting. It's all day long. Glyburide is 50% hepatically eliminated, 50% renally eliminated. The other two are mostly hepatic. So in an elderly patient who has declining renal function, glyburide is going to start accumulating, and then that duration starts going out to 36 hours, and then they took a dose. And then that goes to 42 hours, and then they took a dose, and then somebody's rummaging through their purse to get their glucagon. Okay, so prolonged effects in renal failure. So when I was in pharmacy school, glyburide and glipizide were the only two on the market. I didn't have glimepiride. And so we used to say glip is hip in the elderly because it's hepatically eliminated, don't have to worry about the renal dysfunction. So think about that if you were presented a case and they had renal dysfunction, you would preferentially not want to use glyburide. So those that are hepatically metabolized, you do, in patients who have hepatic impairment, you do need to watch the dose also. Again, not only because they'll accumulate because it can't be eliminated, but also remember, as your liver declines, you don't have that same gluconeogenesis, so you may get yourself into a pickle. Renal excretion, glyburide, the cutoff is 30 mLs per minute for creatinine clearance. But again, I would caution use in patients who even start getting down to the 50s and the 40s. It's going to start accumulating, and then your number one side effect is hypoglycemia, and hypoglycemia. Next reaction that you have to worry about with the sulfonylureas is it does have a sulfa moiety. So you do have to worry about allergic reactions, dermatological reactions, including like if patients are out in the sun, they can easily burn, and then rash in general. So big problems, again, because they have the sulfa moiety. If patients have a sulfa allergy, they may have that cross-allergenicity, and then the photosensitivity reactions as well. GI disturbances, you do have to monitor, especially for patients with declining hepatic function. Watch your enzymes, your liver enzymes. And another downside to sulfonylureas is they cause weight gain. So you have a diabetic patient who now you put them on an exercise regimen to keep them down to a weight, keep their blood pressure down, and you put them on a drug that they gain weight on. So Not one of the most good characteristics of this type of drug. Okay. The next class are the meglitinides. Their mechanism of action is the same as the sulfonylureas. So it works on that sulfonylurea receptor, causes that cascade of events where you block the ATP potassium, depolarization, increase in calcium, release of insulin. They are structurally related to sulfonylureas, except they don't have a sulfa moiety. So patients with a sulfa allergy could get meglitinide class, but they couldn't get the sulfonylurea class. There's 2 agents in this class, and again, can only be used in type 2 diabetics. Again, think of the mechanism. You need insulin. All this drug is doing is it's helping excrete the insulin that your body already has. So what's the number 1 side effect of this class? Hypoglycemia. What's number 2? See, you guys are right. Okay, some differences between these 2 classes. Onset of action 15 minutes, but duration is less than 4 hours. So if somebody had a good response to the sulfonylureas, but they consistently forgot to eat lunch and somebody was rummaging through their bag, so now meglitinides might be a better choice because they can take a dose before they eat breakfast, they can take a dose before dinner, and they can skip that lunchtime and they won't have insulin secretion because the duration of this class of drugs is only about 4 hours as compared to how long with the sulfonylureas? About 24 hours, right? So this is good for patients that skip meals because it has a shorter duration of action. Good for patients who have a sulfa allergy because you won't have that cross-allergenicity. It is metabolized through 3A4, so you do have to worry about some drug interaction. So if you have a strong inhibitor, you're going to increase the concentrations, perhaps increasing the duration that the drug's effect goes on. You're not limited in these patients with renal insufficiency. So again, maybe somebody had a really good response to a sulfonylurea, but they got a little bit older, their kidneys got a little bit poopier. So then you could switch them over to meglitinides. Again, this is going to be the same mechanism. It's just going to have a shorter duration. Again, hypoglycemia is a problem and weight gain is a problem. Same mechanism, but you don't have those dermatological issues with this drug class. Next are the biguanides. The mechanism of this class is they decrease hepatic glucose output. They also increase peripheral glucose uptake and utilization. So this is the first class of meds we're talking about that has nothing to do with insulin. It has everything to do with utilizing the glucose that you're taking in. So with these drugs, you're going to take it in more, you're going to use your glucose better, and the liver is going to store it, and it's not going to put out as much glucose. So the glucose exposure that you have is what you're intaking. And what you're intaking, your body is using it better. So as you see in the adverse effect profile, what's missing from here? Hypoglycemia. Right? So in agents that we're going to alter the way our glucose is used, we're not going to affect the insulin concentrations, and we're not going to see hypoglycemia. Now, can you? Sure. There's going to be that 1 in 10 million people that gets hypoglycemic, probably for a different reason. These agents generally do not cause hypoglycemia. In general, you're going to use this in a type 2 diabetic. Not because you need endogenous insulin still. We're just changing the way our body uses glucose, but you still need insulin. So our type 1s aren't going to benefit from this. Sure, they need to probably use their glucose a little bit better, but they also need insulin. And this is not affecting insulin. So you have one drug. It's pretty well used in our diabetic population, which is metformin. Now, other adverse effects that you need to know with this drug is lactic acidosis. So this drug is renally eliminated. When you look at the package insert for this drug, there are specific cutoffs of creatinine clearance, and there are those for men and those for women. At these cutoffs, you cannot legally not be held responsible. If somebody goes into lactic acidosis because accumulation of this drug, and they have a creatinine above this, I see so many lawsuits for this. You need to monitor patients' creatinine on this drug. It will accumulate, and it will lead to lactic acidosis. If patients have hepatic impairment, they have the inability to eliminate lactate. And so if they have, let's say, renal decline, and they have some lactate buildup because their renal function is not as good, and then their hepatic system isn't as good and they can't get rid of that lactate, they also are going to be in trouble. Also, you have to take into account patients with hypoxic states, so patients with heart failure. They have decreased perfusion to their kidneys, decreased perfusion to their liver. Those patients are also at risk for accumulating metformin, leading to that lactic acidosis. Now, there's a caution with these drugs with iodinated contrast material. It's not necessarily a drug-drug interaction, but if any of you have worked in an institution or sent somebody to get a CT scan with contrast, you will always hold the patient's metformin at least 24 hours before and sometimes 24 hours after. It's not that the contrast directly interacts with the metformin, but what does contrast potentially do? Decreases your renal function. It may be transiently, it may be prolonged in some patients, but that transient decrease in renal function from contrast material is enough to cause increased concentrations of the metformin and lead to lactic acidosis. Okay, so it's not a drug-drug interaction per se, but it is the renal function that transiently declines, causing decreased elimination of metformin, causing that lactic acidosis. So again, we don't see hypoglycemia here, so that's one of the advantages of this drug. Another advantage is that you actually have weight loss with metformin, and you will also see a decrease in triglycerides. So really good things with metformin that you'll see, and that's why it's the most used in patients with diabetes. But probably the number one side effect that patients can't tolerate are the GI symptoms associated with metformin. Lots of bloating, lots of flatulence, and you have to get over that and be able to tolerate that, and it is quite intolerable, and that's why patients generally take themselves off of this medication.
For the lactic acidosis, is it because of the metformin itself, or does it what is the...
Yeah, with high levels of metformin, you'll just shut down the mitochondria, and that causes the lactic production.
The drug that does that?
Mm-hmm.
Okay.
Yeah. Our next class are the alpha glucosidase inhibitors. So you normally have this enzyme that break down complex carbohydrates. So you eat a sandwich, and your alpha glucosidase enzymes break down that sandwich into simple sugars. So what we're going to do with this drug is we're going to inhibit those enzymes. So you take in your sandwich, you're going to inhibit these enzymes, and that sandwich is going to break down into simple sugars much, much slower. Okay? So again, we're going to inhibit the enzyme that breaks down those complex carbohydrates into simple sugars. This can only be used in type 2 diabetics. We're not affecting insulin concentrations. We're not giving back anything, so it can only be used for type 2 diabetics. Will you cause hypoglycemia with these agents? No, you shouldn't see it. We're not changing the insulin secretion, production, or anything. All we're doing is we're taking that sugar and we're doing something different with it. We're inhibiting that enzyme that breaks down those complex carbohydrates into simple sugars. You see lots of GI issues. So those complex carbohydrates are going to sit right here. And you're going to get bloating and flatulence and lots of stuff that patients are not going to tolerate. So that's generally why these drugs are not used and patients will take themselves off, or because of the GI issues.
Are a lot of GI medications then prescribed, or OTC meds suggested for these patients?
it generally doesn't even help. The question was, can you give GI medications like what, like Maalox or Tums or something, and it's not enough to overcome the GI issues. Acarbose specifically has an increase in transaminases, so you do have to monitor liver function tests at patients on very high doses. And if patients at baseline have GI disturbances, then these are contraindicated for those patients. The next class, thiazolidine diones. You have 2 drugs in this class. The mechanism, again, now we're going to bind to the nuclear steroid hormone receptor that promotes glucose uptake and skeletal and muscle adipose tissue. They're taking in all that glucose. Additionally, with this, you have decreased insulin resistance. You'll also increase insulin sensitivity. However, you have no effect on insulin secretion. So will you see hypoglycemia? No, right. We're changing the way we're going to utilize and uptake glucose into our skeletal, etc., and muscles. Only can be used in type 2 diabetes. The adverse effects of this are pretty significant. Back in the 1990s, actually one drug in this class was completely removed from the market for about 30 some odd cases of patients who went into hepatic failure and died. So there are 2 left on the market, but we got lots of problems with these drugs. And they are still hepatotoxicity and edema. And I have another slide on the edema portion. Fracture risk has also been associated with these drugs. It reduces osteoblast activity, so the ability to build bone, and it increases urinary excretion of calcium. So patients who are at risk for osteoporosis or who have osteoporosis should not receive these medications. There is also a loose association with one of the drugs in this class, pioglitazone, where it's been associated with bladder cancer. However, the FDA has not ruled that it is a loose they have not ruled that this drug causes bladder cancer. It is a loose association that has been found in large clinical trials. So right now, the way it stands in the package insert is that if somebody has active bladder cancer or who has a history of bladder cancer, they should not get this drug. And then in regards to the edema component, patients with congestive heart failure should not be prescribed this drug because it may exacerbate their heart failure in some patients. So if patients have established class 3 or class 4, these are pretty severe heart failure patients, it is contraindicated. However, in any patients who have class 1 or class 2, it is recommended that if you initiate this drug in these patients, you need to follow them for signs and symptoms of worsening heart failure. Just again to show you lots of combinations of these drugs to increase compliance. A lot of the combinations you'll see metformin as your backbone and then some of the other medications. Again, a good review slide. Take this slide, print it out, look at the components, know the mechanism, know the drug class. There's a good study guide to use. But you're going to see lots of patients coming in on these combo drugs. You're going to look it up and you're going to know the components of that drug. Now, the next class of drugs are the incretin-mimic drugs. What normally happens in the GI tract is you intake food, and you have this enzyme called glucagon-like peptide 1. And this enzyme causes the stimulation of insulin release, delay in gastric emptying, and suppresses postprandial glucagon release. So all these good things that GLP-1 does. However, the problem is this hormone, our endogenous hormone, is rapidly degraded by DPP4, or dipeptidyl peptidase 4. So it would be nice if we had drugs that mimicked GLP-1 because it does all these good things. Because our body naturally will do this, but it is rapidly degraded by DPP4. So we have some drugs that are recombinant and share about 53% of the amino acid sequence of GLP-1. So when we take essentially a drug that acts like GLP-1, we're getting all those benefits of insulin secretion, all these delayed gastric emptying, suppression of postprandial glucagon release. Because it does allow for some insulin secretion, but it still can only be used in type 2 diabetes. It doesn't give exogenous insulin, so it can still only be used in type 2 diabetics. Now, these agents come as pre-filled pens for sub-Q injection. They can be administered several times, or once or twice throughout the day. You do have to be careful. In renal failure, this drug will accumulate, and so you do need to adjust the dose. The adverse effects, probably the number one adverse effects that has now been seen and is kind of in the press is pancreatitis associated with this class of medications. So these are the other problem with these drugs is they're coming as pre-filled syringes. What else comes as pre-filled syringes? Insulin, right. And these two have been mistaken. Type 1 diabetics have taken this, and they have not done well with this. Oh, I should also recommend too, kind of new precaution that's come out, again, a small link to thyroid cancer with the GLP-1 agonist. So again, if you have a personal or family history of this type of cancer, it is not recommended to use it. Again, the FDA is still looking at large clinical trials. This was a loose association, but really trying to find if it is strong association or not. So then alternatively, thinking about this also, we can increase our own natural GLP-1 by inhibiting the DPP-4 enzyme. Remember that DPP-4 enzyme is what degrades the GLP-1. So we don't have to take in GLP-1 as we previously talked about with the class. We can inhibit that enzyme and just use our natural GLP-1. And that's what the DPP-4 inhibitors do. And you have about 4 different ones that are on the market now. Again, can only be used in type 2 diabetics. It is once a day administration. Again, has to be monitored for patients with renal dysfunction in terms of dosing. And again, your DPP-4 inhibitors, hot on the presses, causing many cases of pancreatitis. I think we're close to our second last class. These are actually brand new to the market, probably about a couple years ago. This is what normally happens in the body here. You intake, your glucose goes into your renal tubules, and you have different parts of your nephron that have different rates of reabsorption of glucose. So kind of our same concepts of like thiazides and sodium and so forth. So ultimately, when you pee, you should have no glucose in your urine, okay? Because you've reabsorbed into your bloodstream 100% of that glucose. However, with these drugs, we're going to inhibit this sodium glucose co-transporter that works about here, where you're going to inhibit this reabsorption, and so you're going to get a fair, substantial amount of glucose in your urine. So that's how you're going to eliminate glucose. So there's 4 different agents on the market. To date, and here you have your mechanism if you want it written out for you. I have not seen anybody yet prescribe this medication. Only good for type 2 diabetics. Again, renal dysfunction you need to worry about, but I like this slide. It has some good advantages. Certainly, when you get rid of glucose, you get rid of calories. So it's going to be a good drug to get rid of, or to allow for weight loss, especially in a diabetic patient. Low risk of hypoglycemia with these, and you may even see some blood pressure lowering effects with these agents. But I think why I really haven't been convinced yet and seen this prescribed yet is its concern is what follows glucose also is water. So you might see a lot of patients with polyuria that are also going to come in very dehydrated at some points too. Additionally, you might see some electrolyte disturbances because some of your magnesium and calcium might follow glucose as well. You may see that decreased blood pressure, which may be beneficial, but I've seen studies where patients have actually had to have subsequent other therapies to raise their blood pressure. Now, that may be related to the drug's effect and its natural mechanism. We're not sure yet. Or it may just be related to the fact that they're dehydrated, that they have this significant lowering of blood pressure.
Will that cause a hypernatremia as well?
We haven't seen hyponatremia. Hyper, but not hypo. Is that what you said?
Yeah.
Sorry, yes. Additionally, you're not supposed to have glucose in your urine. So you may be at increased risk for bacterial infections, so specifically coming in with UTIs. Fungal infections as well, and then again there's a loose association with malignancy. So a lot of the disadvantages probably outweigh some of the advantages. It's a novel drug and it's a good concept to get rid of the glucose you're taking, but it may just not have the same clinical effectiveness as some of our other drugs that we have. And then finally, the last drug I have to mention, very infrequently prescribed, are the amylin analogs. Now, when you look at what amylin does, it slows gastric emptying, decreases glucagon secretion, and glucose output by the liver. This is the only other drug that can be used in a type 1 diabetic because it is essentially a hormone replacement of what we would normally have. You have to use it in combination with insulin in a type 1, but it can also be used solely in type 2 diabetics. This is not generally used in type 2s. I would say if you see this drug at all, it's going to be in a very brittle type 1 diabetic, hard to manage on high doses of insulin. You can think about adding this in to have some synergistic effects. You can see severe hypoglycemia with these agents, especially when it's used in combination with insulin. It's like 2 hits, hypoglycemia from 2 drugs, and so you do have to monitor your glucose very, very carefully with this. Okay, so this is where I have you put your pens down, and we just talk about a little bit about how do we manage these patients with everything that we've talked about. Well, the first thing you need to set is a goal hemoglobin A1C. And our target is about here to 6.5 to 7. Where patients are coming in and around this, you could probably manage these patients with simply diet and exercise and maybe a little bit of metformin. Remember, metformin has the advantages if it doesn't cause hypoglycemia, manages the glucose that we have, causes some weight loss, decreases triglycerides, so all these good things. And then you get these middle folks, and then you get these folks that are coming in with really high hemoglobin A1Cs. Notice what the first drug is here, is insulin. So this is where I said in those type 2 diabetics that come in and they're very, very uncontrolled, you cannot start with an oral agent. You're going to have to start them on insulin in order to get that hemoglobin A1C down. In these middle folks here, you can start oral therapy. The higher you get, the more oral therapy you're going to be on. But also notice that metformin is essentially the backbone of every A1C. Additionally, you're going to take a number of other things into account, the cost of therapy, lifestyles of patients. We've talked about people who skip meals. Maybe some drugs are not going to be good agents, especially those long-acting agents that are over 24 hours. Comorbidities, especially taking into consideration renal dysfunction and how we're going to dose adjust or think about how we dose those medications. Sometimes preference. If people like injections, never met that person, versus people that want to take oral medications. I'm not going to go over these. These I kind of just made because we did go through a lot of medications, so I broke this down into their primary glycemic effects, benefits, and limitations. So I wouldn't say rely on this table 100% when, I think you need to look at all the slides and understand it, but I just thought I would highlight some of the things for you because, again, this is a lot to digest, and certainly listening to me talk for now 3 hours is a lot to digest. So we'll skip through these slides. So here's a test question. Let's see how many of you are paying attention. Which preparation of insulin is released and absorbed at a relatively constant rate over 24 hours after sub-Q injection? Huh? Glargine, 4. Good. Yeah, see? All right, you have this. Let's see, do I have another question? Which drug is administered just before meals to increase insulin release and control postprandial glycemia? Pause, reread the question. Because it's a tricky question. What? Very good. Okay, so where did people make the mistake here? All right, reread the question. Know your mechanism of actions of these agents. Okay, last one. Metformin primarily exerts which effect on glucose metabolism? Okay, decreases hepatic glucose output. It doesn't increase absorption from the gut. It takes the insulin, it utilizes it more, and decreases output.
For the agents that cause hypoglycemia, the oral agents, do you still check your blood sugar before every meal and at that time, or is it like less frequent?
Yeah, that's a good question. The question is for the agents that cause hypoglycemia that are oral agents, do you check your blood glucose routinely? I would say probably patients are still checking it throughout the day. I don't, maybe like in the morning and at night if they have problems, but it's not the same as if you're on insulin because that's such tight insulin control, glucose control. Okay, I have a couple cases. I'll give you guys 10 minutes. We don't have much of a go. No?
There's only one case.
There's one case? Do you want 5 minutes then? 5 minutes. I'm getting lots of looks up here. It'll be over shortly, I promise. All right, our patient case is a 66-year-old man who comes in with history of MI, recently diagnosed with type 2 diabetes. His hemoglobin A1C is 10.5. Which of the following sets of drugs are best to initiate? So how many said A, B, C, and D? Awesome. Nice job. So the patient's hemoglobin A1C is above 10. We've got to bring that down. The only way we're going to be able to do that is by initiating insulin, as oral agents will probably not achieve that. Yes?
If you get some insulin goals and you can step them down, or like it's not like once you're on insulin, you're on insulin forever.
The question is, once you bring them down, can you switch them over? I suppose you could. You probably wouldn't, though, because they probably would end up just like whatever their severity of illness is, unless it's something where they're coming in with DKA. You need to initially get control and so forth. But somebody with a hemoglobin A1C of 10 is probably going to need insulin lifelong. Okay, so we only have a couple more topics, and these should be pretty brief. The first one we'll talk about thyroid diseases. So we have our thyroid hormones. Really, T3 and T4 are essential two hormones that the thyroid does excrete. And iodine is an essential component of both T3 and T4. And with that, of course, we need thyroid hormones in order for growth and development and to maintain our normal metabolic needs. Now, I have on the next slide, I have all the words, but again, I'll grace you with my picture of a thyroid gland. And so outside the body, you ingest iodine. And iodine goes into the thyroid gland, and it combines with tyrosine. And you make T1s and T4s. With the combinations of T1s and T4s, you will make T3s and T4s, and those will be excreted by the thyroid gland. Now, T4 is solely excreted by the thyroid gland, and only about less than 20% of T3 is excreted by the thyroid gland. Most of your T3 in the periphery comes from the peripheral conversion of T4 to T3. Okay? So 100% of T4 comes from the thyroid gland. Only a small percentage of T3 comes from the thyroid gland because most of your T3 in the periphery is because of the conversion of T4 to T3 in the periphery. And T3 is your active hormone. And there's in words. Now you have hyperthyroidism, where obviously you have too much thyroid hormone. This can either be Graves' disease, you have antibodies to your thyroid, or certain medications such as amiodarone. And you see your lab abnormalities of elevated total T4 and free T4, and then you see a suppressed TSH level in these patients. So how are we going to treat these patients? Well, there's really three options. One is surgery, taking out the thyroid gland, but then you're going to simply induce a state of hypothyroidism. There's a number of pharmacological therapies we can use, and radioactive iodine. Now, radioactive iodine, again, will destroy all thyroid tissue, so essentially inducing a state of hypothyroidism. So first, really focusing on the medications that we can use. There are thioureas, and there's two thioureas. There's propylthiouracil and methimazole. And really their actions, in words, there's what it is. Let's go back to our thyroid gland. So here's what we're doing. So with PTU is propylthiouracil and MMI is methimazole. Both of these agents will inhibit the coupling of iodine to tyrosine. Both of these agents will inhibit T1s from combining to T2s. But only propylthiouracil will inhibit the peripheral conversion of T4 to T3. Okay, so methimazole has two mechanisms by which it works. It works in the thyroid gland by inhibiting the coupling of iodine to tyrosine and T1s and T4s, so ultimately decreasing T3 and T4. And then propylthiouracil also works outside of the thyroid to inhibit the peripheral conversion of T4 to T3. And again, one slide before, there's your words. These agents do not change preformed thyroid hormones. So they're not taking anything away, they're just preventing more T3 and T4 from being formed. So it's not affecting levels of preformed T3 and T4. So that's why it takes about 1 to 2 months to really see the effects of these agents, because it's going to take time for these drugs to inhibit newly formed T3s and T4s. It doesn't take away any of the current hormones that are around. Essentially, these agents are well absorbed from the GI tract, and although PTU is highly protein-bound, so why do I ever tell you about highly protein-bound drug? Because of drug interactions, right? So you give two highly protein-bound drugs together, someone's going to get knocked off, and you're going to have increased concentrations of another drug. We already said, kind of in another way to say this is that these agents have short half-lives in general, so they need to be taken very frequently. But once they act, they have long-lasting effects because they're inhibiting the formation of new T3 and T4. Again, not taking away any of the preformed thyroid hormones, but preventing the formation of new. And so up front, they need to be taken very frequently because they have short half-lives, but it has long-lasting effects because it's inhibiting the formation of hormones, formation. Problems with these agents, rash. You do have to monitor patients with rash. If somebody gets a rash, they should stop it immediately. I have seen some patients go on to develop almost like a Stevens-Johnson's-like reaction where their skin starts peeling off. So with a rash, you do need to stop these medications. You will also see fluid retention. So bad if you're using these patients with heart failure or other disease states where you're trying to get volume off. So you will see fluid retention. And finally, a lot of these agents can cause a significant decrease in white blood cell count. If it is caught early enough, it is reversible. If it is caught very, very late in the course, you can have permanent bone marrow suppression and permanently decrease white blood cell generation. So you do need to monitor fairly frequently patients' complete blood count in a differential. Now, iodine-containing compounds can also be used transiently. This is not something that you would keep patients on long-term. So these are a bit counterintuitive. So you think about something as iodine, you would think, well, iodine combines with tyrosine to make more T3 and T4. But in actuality, when you hit the thyroid gland with an overwhelming amount of iodine, it shuts the gland down. It's like, whoa, too much. Like if you're a candy lover and someone's going to slip you a little Hershey bar, you're like, oh, that's great. But they give you they dump all these Hershey bars. It's like, whoa, I can't eat that many. So you're just going to shock the thyroid gland when you overwhelm it with iodine. I know, bad analogy, but I was trying to give you something. It's getting late and I'm getting a little hypoglycemic. But you'll never forget it now. So you overwhelm the thyroid gland and it just stops producing T3 and T4. So where you're going to use this, and you can have glucose solution or potassium iodide solutions, is when somebody's going to surgery. So it's kind of like a prep in order to go to surgery. Because you wouldn't want somebody with active hyperthyroidism going to surgery. Your thyroid gland is producing a lot of substances. You want to shock the gland, and then you want to be able to take it out so it's not producing all those hormones at once. Has a lot of different adverse effects, from metallic taste, can cause a rash, GI. All of these are going to be transient. You're certainly not going to use these drugs long term. Again, this is short term, typically used before somebody goes to surgery. For patients with real significant hyperthyroidism, they get essentially like a adrenergic storm. And you can use beta blockers to also control some of those signs and symptoms, the heart rate, the blood pressure issues that you see. Additionally, beta blockers also inhibit the peripheral conversion of T4 to T3. So you do get an additive benefit with your beta blockers. Generally, your non-selective beta blockers are chosen, so something like propranolol. Remember, when I say non-selective, it's your beta 1 and your beta 2s. Okay? So again, you're going to control adrenergic symptoms associated with hyperglycemia. See, now you guys got me. Hyperthyroidism, and also inhibits the peripheral conversion of T4 to T3. And if you think about this too, well, I'll talk about it later. I don't know, does that? Well, I was going to talk about, so I just want to mention this because amiodarone can cause both hyper and hypothyroidism. And so I just want to spend a moment of why it does both. So it can cause hyperthyroidism because, remember, it has that iodine moiety in amiodarone. So amiodarone can cause hyperthyroidism because you have a constant source of low doses of iodine. And so your thyroid will take constant iodine and make T3s and T4s. Now, amiodarone can cause hypothyroidism because, remember, it has beta-blocking properties. So it can inhibit the peripheral conversion of T4 to T3. If you remember from your cardiovascular lecture, it has all those von Willebrand properties. So with beta blockers, though, you have the same issues: decreased blood pressure, bradycardia, congestive heart failure, asthma patients you want to be careful in. For hyperthyroidism, corticosteroids can also be used. It will decrease the thyroid action, especially if somebody's having an immune response, and that's the source of their hyperthyroidism. So again, that can control the thyroid gland, decreasing the inflammation, decreasing the amount of T3 and T4 that is released. Now, the opposite, you have hypothyroidism, and again, you can have Hashimoto's. It can be because you had your thyroid gland taken out, or again, medications like you highlighted, amiodarone. And you'll learn next week with your antidepressants, antipsychotics, with lithium. Lithium can also cause significant hypothyroidism. Lab aberrations, you'll see decreased T4 concentrations and elevated TSH. Our therapy here is going to be to give back thyroid hormones. So we have our natural thyroid hormones, of which there is still thyroid armor, which is still out on the market. Very few patients are on this. It does come from animals. So they take animal thyroid and they chop it up and they put it in here. So initially when this first, it made sense, before we had the ability to chemically engineer drugs. And so we would take animals and use the thyroid. And and some practitioners for a very long time continued to use this even after synthetics came out, because they thought, well, this is natural thyroid. So I'm going to get the natural concentrations of T4 and T3 and give that back to a patient. So they're getting the same, essentially, ratio of T4 and T3. But the bioavailability is unpredictable because you're taking a little bit of thyroid from a sheep and a little bit of thyroid from a cow or something, and you're combining it. Nobody really knows what you're really getting. So the bioavailability was unpredictable. And of course, as you would imagine, you have those immunologic reactions. You're giving something foreign, and so a lot of people will have those types of allergies. So really, we depend on our synthetic thyroid hormones for replacement, of which there are 3. Probably the number one prescribed 90% of the time you're going to see Synthroid. And Synthroid, or levothyroxine, is really the generic name. And it comes under a lot of different brand names, a lot of different manufacturers of levothyroxine. It is chemically stable, it is free of antigenicity, and it is inexpensive, and that's why it's the most commonly used. And we're going to talk about in the next slide a little bit more about levothyroxine. But you have a few other agents. You have pure T3. Remember, T3 is your active thyroid hormone. So if you have somebody with really severe hypothyroidism, you don't necessarily only want to give them T4. So levothyroxine is a complete T4, so not actives. So with here, you're giving complete T3. You get a little bit more high incidence of cardiac effects. You give too much thyroid hormone, you're going to induce hyperthyroidism. You're going to shift somebody into an MI. Very expensive. And then last, because they chemically engineered lithotrix, which is a ratio of T4 to T3 in that 4-to-1 ratio, trying to mimic the animal thyroid, very expensive. In head-to-head trials against levothyroxine, no benefit, just a lot more money. So spending a little bit more time on levothyroxine, it actually is considered a prodrug. So you're giving 100% T4. T4 is not active. T4 has to be converted peripherally into T3, into your active hormone. So levothyroxine, again, is completely T4. It will produce physiologic levels of T3 and T4 over time, but it will take a while to get there. So you need to wait about 2 to 3 weeks in order to see the effects of the drug. So you have somebody, you diagnose them with hypothyroidism, you prescribe levothyroxine, you do not have them come into clinic the next week to then increase their dose. You have to wait at least a good month in order to get those physiologic levels with Synthroid. Adverse effects, you can see heart failure, angina, MIs, and then you can induce hyperthyroidism. So in general, mostly well tolerated, but if you overshoot the dose is where you're going to get into troubles with these side effects. So oftentimes a general starting dose is about 50 micrograms. In the elderly or patients who already have some underlying cardiac issues, you'll start with about half that dose. So you'll start at about 25. All right, like a sample test question. All the following describes the mechanism of action of propylthiouracil except, let you guys read those. How many say 1? How many say 2? 3? 4? Oh boy, I'm losing you. Definitely losing you. It's good that we only have about 10 more minutes. Okay. So adrenal glands. There's really just one big concept that you guys need to know about this. Obviously, the adrenal glands are responsible for maintaining hemostasis. We said glucocorticoids are produced by the adrenal glands. Really, that's your anti-inflammatory. Remember when we talked 10 hours ago about steroids? We had glucocorticoids, and I showed you the different potencies because that's the anti-inflammatory effects. But what's important, especially when somebody has renal dysfunction, is also the mineralocorticoid effects. And that really maintains sodium and water hemostasis. So when you're dealing with somebody who has true adrenal insufficiency, you have to give back kind of a ratio of glucocorticoid plus mineralocorticoid in order to maintain hemostasis. Now, over time, adrenal androgens that are produced may have to be replaced. But really, your two big things that you have to think about is glucocorticoid activity and mineralocorticoid activity. So with adrenal insufficiency, we've kind of already talked about the different steroids, but what I want to highlight here is especially somebody coming in with crisis is you are going to give them an IV form of steroid, and then you're going to supplement them with some sort of oral steroid. And whether they need to be maintained on an oral steroid, at low dose or high dose, you're going to have to monitor the patient and always get them to the minimal dose as possible. But one thing I want to highlight is there's two different salts of hydrocortisone and methylprednisolone. There is the succinate form, and there is the acetate form. Now, in general, if you mix them up, you're not really going to harm somebody in the sense where you're not going to cause like necrosis because the salt doesn't cause any damage to muscle or so forth. But it's the onset of action. So if you gave somebody the acetate form of a steroid and you gave it IV, the acetate form acts much, much longer. Think about if you ever or hear about patients who have knee problems and you say, oh, I got a steroid injection and it lasts them a month. It lasts them a month for a reason, because the acetate form doesn't disperse right away. It is very, very slow. So you give it IV and it's very, very slow and somebody has an adrenal crisis, that's how you're going to harm them. So you always want to make sure for IV that you're using the succinate form, because that is where the onset of action is much, much faster. So I would probably get in trouble for swearing, but it would suck if you don't choose the right form. Okay. Write me up. All right. Last concept. You've seen this slide before. I would highly recommend that you are able to interchange on glucocorticoid potency. I've added now a column of mineralocorticoid potency. In somebody with adrenal crisis, which corticosteroid would you not want to give? If somebody with adrenal crisis came in, which steroid would you not want to give? Dexamethasone. It has zero mineralocorticoid activity. Remember, in somebody coming in with adrenal crisis, you need to give them a combination of glucocorticoids and mineralocorticoids. Dexamethasone is devoid of mineralocorticoid activity. Okay? Again, you won't have to convert mineral. I would highly suggest you're able to know the difference between giving the equivalent doses based on glucocorticoid. All right, thank you. Have a good evening. Everyone get home safe. She stays free. Thanks. Yeah. Well, that's half the battle. Yeah. Have a good weekend. Thank you.
Thank you, you too.